Good afternoon, everyone. Welcome to the December 11th Governance and Priorities Committee meeting. I'd like to first recognize that we are on the traditional territory of the Snuneymuxw First Nation. Our clerk today is Ms. Karen Robertson. Today's Governance and Priorities Committee meeting will be held in accordance with the Community Charter and Council Procedure Bylaw 2018, number 7272. The question period sign-up sheet is on the table by the double doors to my left for agenda items only. If during the meeting any member of the gallery has a question regarding an agenda item, please write down your name and the agenda item on the sheet. Members have been granted the authority to join meetings electronically. Doesn't seem like we have anyone attending electronically today. The first item on the agenda is the introduction of late items.
Thank you, Madam Chair. We do have Councillor Giselbrecht who's joining us electronically. That just sort of came in. And the late items for today is just the adding of 2 PowerPoint presentations. And the first one is added to item 5B, and it's the PowerPoint entitled Homelessness, Mental Illness, and Evidence to Inform Improvement. And the second is a PowerPoint presentation added to item 5C, which is entitled 2023 Nanaimo Community Action Team Overview.
Thank you. May I have a motion for the adoption of the agenda as amended? Moved Mayor Krogh, seconded Councillor Armstrong. All in favor? Motion carries. We have no minutes today. Our first presentation is Drug Toxicity Data by Dr. Shannon Waters, Medical Health Officer, Dr. Roger Walmsley, Island Health Addiction Medicine Physician, Amanda Lemon, MHSU Manager of Community Services in Nanaimo and area, and Dana Leek, Director with Island Health, to present a presentation on drug toxicity data. Welcome, please come up to the podium.
And do I advance here? Yeah, thanks. So, good day everyone. My name is Shannon Waters. I am one of the medical health officers with Island Health. I am covering interim for the Snuneymuxw region, so I just wanted to acknowledge that you do not have your own designated medical health officer at this point, and I'm doing an interim role, but I'm also covering my usual area, which is the Cowichan Valley Regional District, so I know I in no way can provide the type of service that you might have been receiving in the past.
Thank you so much for being here. If you could speak more closely into the microphone and present to council, not to the audience.
Okay.
Thank you.
So I am myself a member of Stamanis First Nation, so I'm Hulkameetnam, and I just want to start off by acknowledging that we're on Snuneymuxw territory, and Nustli Kwanasitu Snuneymuxw Misteo Otitamal Miskakip Atanaquail Ihaichka. So I wanted to thank Snuneymuxw for the land we are gathered on today, and thank you. So just a couple of things of context before I go into this data. We, in public health, look at interventions across the population in terms of mental health and wellness. For all British Columbians, we look at mental health promotion strategies, and as people might have more intensity of the things they might be dealing with in terms of their mental health, we have different services and levels of intervention at those different levels of the population. So the data that we're talking about today is largely people who are at, the tip of the triangle here, where we're looking at increasing levels of intensity for what we might be able to provide in terms of therapeutic intervention. I also want to acknowledge that in talking about substance use, almost all of us as a population are somewhere on the spectrum of substance use. There's things from beneficial use, like coffee or tea, that many of us might have to start off our day, or at many points throughout our day, some of us. And then we have people who might be moving along the spectrum to things where they have chronic dependence, which is compulsive and habitual use despite negative health and social effects. So in my earlier slide, I showed a triangle. This is another triangle, and this is looking at some of the data we have to measure impact of what's going on with drug toxicity within our communities. We do not have data that's available for everything that's going on with drug toxicity events. And so that would be a far greater number than what I'm sharing with you here today. But what I do have to share is data around the BC Emergency Health Services attended drug toxicity events. I was looking at some of the slides that are going to be presented later. I know there's some fire department related attended events as well that will be shared. Also, we have emergency department visits due to the suspected drug supply, and also I'll be sharing some data from the coroner's service around drug toxicity deaths. So as I go into this data, I want to acknowledge and take a moment that this may be people in this room that people are connected to, friends or family members. There's really no one in this province who has been untouched by this crisis. I also want to acknowledge that having been the medical health officer in the Cowichan Valley region, when I took on being interim for this area and saw this data, it affected me really deeply because it's very different and much more extensive than the data that I present within the Cowichan Valley. So this is the number of illicit drug poisonings attended by BCEHS each year. This data is up until October 31st of this year, so about a month out of date, which is usually around the area we run in terms of when we get the new data. Here you can see that the BCEHS attended illicit drug poisonings is far higher in 2023 than it was in 2022. And now the rate is double the rate in Nanaimo compared to the rest of Island Health. So the numbers might look different between different places because of the amount of population, but when you look at the rate, which puts it all over 100,000 population, you can really see how Nanaimo compares to other parts of the island. That works out to this graph here is looking at about how many paramedic attended events, that means per month within this area. So that is averaged over the previous 12 months, about 89 attended events per month. And you can see during 2023 that really started to rise quite significantly within the late spring. This is looking at the same data through different demographics, so age demographics, and then I want to acknowledge this is a female-male binary here. We do not have gender beyond female-male from the coroner's office, but you can see the highest rate is in the 25 to 44-year age range, and a higher rate in males as well. When you look at the location of these events, you can see that there is an increase in the amount that are being attended in the outside area. If you look at the fourth to last columns there, the light blue being 2023. So less this year in private residences and more in the outdoors that are attended by BCEHS. When we're looking at the location of where a lot of those are occurring, the darker red color means more attended events. So this graph is showing that there are some pockets. It's not only in one part of this region. You can see some different shades of orange, but there is a concentration of red here within the downtown area. When we look at emergency department visits, here you can see again when you're looking at the numbers for the rate rather for Greater Nanaimo versus the rest of Island Health. Again, a higher rate, 1.7 times the rate in the rest of Island Health, and again, a marked increase in 2023 compared to 2022. And this is the tip of the triangle where we're looking at deaths due to the toxic drug supply. And we have, we had 85 Greater Nanaimo residents lost their lives to drug toxicity in 2022, and a further 99 have lost their lives in the first 10 months of 2023. And that is a rate, again, markedly different than the rest of the island, more than double the rate of the rest of Island Health. When you look at that month by month, over the averaging over the previous 12 months, we have about 10 deaths a month here within the province. And you can see there has been some variability as the months of the year go on, which is not unusual for when we look at this data across different parts of the island. But in generally speaking, about 10 deaths per month. Again, looking at it by a demographic background, highest rate for deaths in the age bracket of 25 to 44, and again, higher rate in males compared to females. Over the past year, the rate of illicit drug toxicity deaths amongst those in the 25 to 44 year age range was 2.7 times higher in Nanaimo than the rest of Island Health. And when you look at location again, there's a bit of a trend similar to what we'd seen with ambulance-attended events. So there is an increasing percentage happening in the outdoor area. And when we're looking at where this is occurring, again, it is not only, it's across the region, but the concentration, the darker red color where there's more deaths is within, central Nanaimo. So I know that's some difficult data and it may generate some questions, but I am very grateful for the opportunity to share this with you here today, because I think this is something that's complex, pretty devastating, and something for all of us to work together on. So with that, I'll raise my hands and say hi, Sapka. Thank you for the opportunity. I want to acknowledge those who are here from Island Health with me as well, who can help answer questions that people might have.
Thank you very much. In orders, I have Councillor Hemmons, Armstrong, and Manley.
Thank you, Chair, and thank you, Dr. Waters, for being here and presenting this information to us. I agree, very difficult statistics. My question is in relation to your 14th slide and the 2.7 times higher rate of drug toxicity deaths than elsewhere in Island Health, and I'm curious what Island Health's response is to that, and whether we get a different allocation of resources due to the increased vulnerability of our community.
I can start off by saying certainly we look at this information in terms of what's going on throughout the region. So I'm a public health physician. We use this type of data as our kind of lab work for a population versus when people might see others individually. So this makes me think we gotta be looking at what we're doing here within this region. And that's why I was really grateful to be able to have the opportunity to come here today. I have partners who are working more on the operational side, but I think what we need to look at is in this specific age range, what has changed in the past year, and what can we look at doing differently or bolstering, different types of approaches around. So I don't know if others want to make a comment.
I do want to recognize the statistics are new, and this problem has newly come to light, although I think anecdotally a lot of people knew this. But so I recognize it's a bit of an unfair question, but I'm curious about the systemic response when we see such a variability in the statistics.
Yeah, and I just wanted to, Dana Like, the director for Central Island Mental Health and Substance Use, is on the call as well, but I'm not sure if she has access to speak. Just want to give her the opportunity, and if not,
I am here.
Okay.
Can you hear me? Yeah.
Yeah.
My camera is not working though, so I apologize for that. For whatever reason, my Zoom camera is not working, so I'm glad you can hear me. Yes, in terms of Island Health's response, absolutely, this is astounding data and just incredibly heart-wrenching in terms of years of life lost that we are experiencing here in Nanaimo. One of the things that many are aware of is that the overdose prevention site at 250 Albert has been operational. We're coming up to a year of that with the expanded capacity with the inhalation addition as well. And the volume of people that are utilizing that resource continues to have high volumes, greater in other areas within Island Health for overdose prevention services. Looking at how we can expand those hours is something that we have been exploring with the operator, which is CMHA, and we hope that we can be able to bolster that service up so that there would be an increase in hours of operation, which is a service that is life-saving. And the other thing that I would say is that the increase in the number of people that are losing their lives, not in private residences or in housing structures, also speaks to the need for housing to be available in the city. And many folks here know that we are working with the city and BC Housing to identify a location for complex care housing, which would enable people to access various streams of the housing continuum, from shelter-based to supportive living into the complex care housing that is coming with 20 net new units. So we hope that we can confirm a location for that and begin the planning. As well, our outreach teams continue to expand as best we can with the human resource crisis, and the primary care outreach team that Amanda Lemon, who's in the presence there, can speak to, definitely has seen an increase in the demand for their services and being mobile throughout the city. Amanda, is there anything that you wanted to add in terms of what your outreach teams and the expansions in terms of the response to the overdose crisis?
Yeah, I don't know that there's anything different that council hasn't necessarily heard from me before, but I think what strikes me with the data is definitely the people outdoors. And for our outreach teams and our healthcare teams, it's so much more challenging and difficult to locate people when they don't have a home or accessing a shelter. They don't have phones. So some of that overdose follow-up from the emergency department, which is one of the things one of my teams does, is a little more challenging. So they're continuing to work really hard on building relationship with the community, make sure community members know where they are, when they can access them, and being as mobile as possible. But it is added challenges, but we're trying to get creative and see what we can do and working with our community partners.
Thank you. I'll follow up later. I'll go to the end. Thank you.
Councillor Armstrong.
Yes, I have numerous questions, but I'll stick to two first till everybody else speaks. One of my questions is are you tracking the stats to see if the age of the people that are dying are using the safe consumption site at all? Is there a way to track that to know? Because we've heard that a lot of the people, and it's more from the private residents, and I know you're focused on the streets, won't go to a safe consumption site because of the stigma.
Yeah, I mean, so when some people access the overdose prevention site, and I'm going to look for clarity, I know in Cowichan there's not demographics that's collected to make it as low barrier for someone to enter. Some people, if they think information is being collected on them when they access, that might affect people attending. Certainly, I think staff who work there can see anecdotally perhaps the age range of people that might be attending. So I'm not here on the ground. I don't know if there's much that can be said from others here in terms of what people might notice about generally the demographic who is attending.
Thank you. And my second question, I was on the fentanyl overdose working prevention group back in 2013 with Dr. Hasselback, and we did a lot of work around that. And one of the things that we noted back then, and I don't know if it's the same now, was the lack of access to mental health for younger people. Do you think that is leading towards people self-medicating? Because we do know, 80% of the population suffers from trauma. So a lot of psychiatrists say, yet 80% of the population is not using drugs. So,
Yeah, like I think that's certainly part of this picture. And I was just going to go back, it's a bit busy, but to that first slide that I showed about like looking at how we respond across the board for all of the population with regards to our mental health. So mental health promotion strategies critical for families, for youth, for adolescents particularly can be a really vulnerable time. So certainly I think that's part of what we need to look at. Coming out of COVID, we know certain populations were more affected. Adolescence, a time when you're, really finding out who you connect with, who your peers are, we're particularly impacted by that. I think some of the data we're seeing here between 1 year and the next, where there had been a marked difference, I wouldn't per se say I think that's what's related for what we've seen with that increase most recently, but certainly I think that's something that we need to look at and address overall as well.
And I would just say, if you go back even to the 90s, Nanaimo always had double the deaths of other areas, drug deaths, especially when it was heroin. So it's not a new stat for me. Thanks.
Councillor Manley.
Thank you, Chair. And thank you for the presentation. These are pretty shocking numbers. I'm wondering, like, is there, are there things that can be related to this change? Like, I know that Nandu was shut down. They shut down their operation, and we see, just in the months that leading up after that, that there was an increase in deaths. I'm wondering, is there an increased rate of addiction in this community in particular? Is there a relationship to access to services in this community that's different from access to service in other communities? Has this kind of been looked at, and why is it that Nanaimo, apart from Councillor Armstrong's point that there has been challenges in parts of Nanaimo for quite a long time? Is there some correlation?
I can speak to theoretically what could be contributing, and there are some much more intelligent people in this room who probably have more data and information. But if you compare even our point in time count numbers now versus say 2020, and the significant increase in people living unsheltered in our community, and our overall total count of individuals who are living unsheltered in this community comparable to available shelter and shelter beds is significantly lower in Nanaimo compared to other communities of this size. So in terms of supporting someone to have more positive health outcomes when they don't have a basic need met, it becomes incredibly challenging. And what we're expecting of people who are already very resilient but are struggling to meet their own basic needs, making huge life changes, becomes virtually impossible. I think too, the toxicity of the substances has significantly changed over the last probably 5 years. So
That would be province-wide, though. I mean, it's not.
No, it's not. It's not new to Nanaimo, but I think again, when people have access to a place to be and where people can find them, there are others around them that can support them in their substance use. So yeah, again, it's just kind of my theoretical. I don't know if Dana, if you have anything else to add to that, or if I missed anything.
No, I think, in terms of the response to the question specifically around Nandu, I think certainly what we've learned is that distributed models of overdose prevention services or safe consumption sites is definitely something to consider. And I think that somebody spoke to that point earlier on about, is there a population that perhaps is not comfortable accessing the overdose prevention services that are contracted through Island Health, and whether there is room for considering what that other models of distribution and service intensity and availability might look like. I think that's definitely something to consider given what we saw as in the early days after Nandu dispersed.
So is there, I hear the part about BC Housing and that overall plan, which is going to roll out over time. It's not going to happen overnight. Is there a more immediate plan on the part of VHA to address this? Anything new to share?
To address the housing specifically?
To address the number of deaths and the overdoses in the community, like opening other OPSs, or I mean that's you really need primary health care to be able to operate some of these things effectively. Is that not correct?
I think in terms of the response as far as Island Health's ability to open up other OPSs, it is a very difficult service to operate in terms of even the willingness and the availability of space and locations, along with an operator to be able to operate a service like that. But certainly something to take away for further review and discussion with MHOs and executive, absolutely.
I'm just wondering about other, pharmacy outlets and the Safer Supply program. Are there plans for wider distribution and for observed use of Safer Supply? Any changes on that front?
Hi, perhaps I can say a word or two, Dr. Walmsley. I'm both an emerge doc, an addictions medicine doc, and a primary care outreach physician, so I think I have some familiarity with some of the issues that we're talking about here. First of all, I think we need to understand that there's no simple solutions, and that's a given here. And addiction medicine, the pivotal words that we all use with addiction medicine is addictions are related to connections. So with the loss of primary care and the declining numbers of well, at least I think it's changing at some level in Nanaimo. We're starting to get more primary care physicians in the local area. So our numbers in that capacity is increasing, and I hope that makes a difference in the long run, even in this community. I think that there are initiatives through AVI. There is Enhanced Harm Reduction Program, which has come up in the last year and is federally supported, as well as locally supported, which I think is providing a level of care which we weren't accessing to quite the same degree before. We're certainly recruiting more physicians into the field. I think it's worth noting, and I think it's probably now public knowledge, that Island Health has reorganized the addiction medicine program within a different portfolio. We now come under public health. And I think the rationalization there is not to discredit the MHSU teams, the mental health substance use teams that Dina and Amanda and I work with locally. It's just to recognize that there are significant social determinants of health and public support, public health initiatives that we need to really bring front and center to this issue, province-wide, certainly island-wide, and really give some visibility to a number of those issues. And I suppose one of the other things that I'm very aware of when I work on the street is the increased amount of homelessness. And I don't think that we can discredit or we can dismiss the challenges that the housing crisis has put on our community. I'm seeing more elderly people living in their cars. I'm seeing people who are not substance users who are faced with homelessness, and that is another factor. And then sometimes what happens is that in that setting, they turn to addictions because that is the way to survive. Many of the people that I deal with on the street, they use drugs to stay up at night because they don't have a warm place to go to. There's not enough shelters in the city to go to house all the people that we have. So I think with no simple solutions, homelessness, primary care, some of the changes in the Island Health organization, we're hoping that we can make a change in some of those areas down the road.
But housing first is key.
I'm sorry?
Housing first, wraparound services, yes. Key. Yeah, thank you.
Thank you, Councillor Perino, followed by Mayor Krogh, Councillor Thorpe, and then a second round of questions with Councillor Armstrong.
Thank you, Chair. There's so many questions. It's just, it's surprising to me that Nanaimo's numbers are higher than other areas. Or am I misreading that? Our ratio appears to be higher than other areas.
Yeah,
Right?
that's correct. When you look at the rates, and the rates are what we use to compare to other regions, yes, Nanaimo is very much an outlier.
So every area in this province has homelessness issues. Are our homelessness issues also higher than in other areas? They are, right? Okay, so that's part of it, okay. I'll tell you the question that I get repeatedly is, and it's hard to defend this, so I apologize for the question, but when you consider that our harm reduction site was opened just over a year ago, about a year ago?
The new OPS?
Yes.
Yeah, it would have been, yeah, it's just coming
About
a year.
ago. So there's so many more deaths already, that what people are saying to me is what a mistake it is that we are giving out, free drugs to help to keep people alive, and yet more are dying. And I don't know how to answer that question.
I'll let Dr. Walmsley come up with it, but it's the illicit toxic drug supply that is taking people's lives, that has different contaminants in it, and makes it more difficult to respond when you're providing an overdose response, like incredibly different compared to 6 years ago, where you administer naloxone and it had good effect. The presentation and complexity of folks, because of the contaminants in the illicit drug supply, makes it so much more difficult to attend and support them through that.
So, I've watched them where they'll come out of the site and sell it on the street for something stronger. And that's been happening quite a bit as well. But I still can't get my head around the fact that we have begun to give out free drugs to try to save lives, and we seem to be losing even more.
So prescribed safer supply has been an issue since it first came out. Yeah. And I know Shannon can speak to the data around, and you've all heard it, no doubt, from our provincial coroner, that there is no data that suggests that safe supply is contributing to more opiate use disorder. The reality is that only 5% of the people who have opiate use disorder are receiving safe supply. That is not alone counting for the increased deaths that you're seeing. It's not accounting for much of what you're seeing. So that combined...
That's very interesting. Yeah, thank you. Yeah.
Out of the 100,000 people that have opiate use disorder in the province, 5% of them are getting safe supply.
That's very...
As a maximum.
Yeah. And that's an important detail, because we miss that piece. And I just want to finish by saying I appreciate that you said there are people in this room that have gone through this in their families and with their friends. I appreciate that, because I'll bet you everybody in this room has someone who has gone through it, and I know all about it. Thank you so much.
Mayor Croak.
Thank you very much. I appreciate the presentation from everyone today. I want to focus in on a subset of the population. I think it's very interesting, the statistics, that the number of folks who are paramed attendances at illicit drug poisonings has dropped from 36% to 23% for private residences, which we were told was, in fact, earlier, where we were all told, a significant portion of the population. Now it's much higher in the street population. And I'm going to focus in on that portion of the street population that have mental health issues, drug addiction issues, brain injury, all resulting from traumatic experiences, I'm sure, for whatever reasons. Is it time to acknowledge that there is a portion of the population who should be in secure and voluntary care, and there are a number of them out in the streets who are not going to voluntarily change their habits, who are so incapable that they're not able to make rational decisions about themselves? Because right now, from my perspective, they seem to be living and dying in our streets without any hope. Their family members write to me, people in the streets talk to me about this. This is not a small issue in our community. We had, as I understand it, something in the range of 6,000 people in care in this province in the 60s, in institutional care, terrible, frightening word for many people, when the population was less than half. So I would really appreciate comments from any of you on that suggestion that it's way past time. It's a small portion, but they are the most vulnerable. They are the most damaged, and they are, I suggest to you respectfully, the most likely to die in our streets.
It's a difficult question. You're asking a historical perspective regarding the logic for shutting down some facilities, which I think we've all questioned at various times. What I can say regarding substance use and committal is that there is no data to support that long-term committal improves the outcomes with substance use. If someone is committed for reasons of substance use, and then they're released, that are a much higher risk of death, of fatal outcome. It's been proven, and there's no indication that it helps in the longer term. We have several examples, even in this community, where we've tried to provide a level of support with a period of committal to see if we can stabilize the issue. Once the committal is removed, then they're at increased vulnerability, and we find that repeatedly. So there's no data to suggest that committal decreases the problem of substance use as a part of the answer to the question that you're asking.
Thank you, and I appreciate you were very careful in your words, and I don't say this as a criticism to talk about the connection between a lack of data and substance abuse. I'm talking about the numbers of individuals who have been brought back with naloxone many times, who do have significant brain injury, who do have serious mental health issues. Substance abuse, with great respect, is almost, from my perspective, a simple problem to deal with. It is the brain injury and it is the serious mental health coupled with the substance abuse. Those are the folks I'm talking about, and it's pretty clear to, I think, most of us in this community that those folks are the most likely to die. They cannot make rational decisions. I'll ask the same question that I've asked of everybody. Why was it no one complained when we put my father-in-law deep in Alzheimer's into secure involuntary care? Why was it appropriate for him, but it's not appropriate, or there's not data to support it, or there's some explanation? Why isn't it appropriate to deal in the same way with people who are clearly not making rational decisions, that notwithstanding the evidence that is out there and available publicly, that there is a toxic drug supply that is killing people, and in this community you're telling us at twice the rate? Why is it that everyone is so reluctant to face up to the reality? I'm not talking about 20% or 50%, I'm talking about that small portion. Those are the lives that, in my respectful submission, are most likely to suffer. So if you can come back and answer the question around the aspect of the serious brain injury and addiction issues, not just the mental health issues, mental health and brain injury, not just the addiction issue, because I'm told, talking to Kix Catton, who's familiar to all of you, the numbers from the Canadian Brain Injury Society are substantial now. Majority of the people who end up on the streets already have an existing brain injury, and it's not going to get better with substance use, particularly the toxic substance that is available out there. So could you try and address that aspect of the question? And I'll understand if you can't, and I understand I'm trying to force you into making what I would call a political statement. But having said that, I think I can safely say I'm speaking for a large portion of the community, if what I'm hearing is correct, who really want something done, who are just as upset by these statistics for a variety of reasons.
I'll try. I don't think that that's a question that any of us can answer. You know, we're even with the Mental Health Act, we're held by provincial legislation and how we deliver service in that way. I think it's an important conversation to have. The only thing I can say is that when people are in a place where services can come to them and be consistent, regular, trusted, their health outcomes improve. When we're not even able to provide that to an individual, we're just going to continue to see these adverse health outcomes. So I think there's a spectrum of support, and it's probably very individualized depending on how somebody presents and what their experiences have been and what their health challenges are. But that's the basic. It's true. Having somebody in a place that's got a roof, being fed, and receiving supports that are consistent and meeting their health needs, things will improve. So that's kind of where we are. But in terms of the broader enforced treatment and things like that, I think those are bigger than me.
Thank you.
Councillor Thorpe.
Chair. Yeah, first I share the opinion of Mayor Krogh, but I appreciate your being here and attempting to answer some very tough, challenging questions, and thank you for the work you do. I guess my question is somewhat related to Mayor Krogh's, and that is this. I hear the statistics, I understand what you're telling us, and it seems to me that despite all of your best efforts, we, to generalize, are basically fighting I'll call it a losing battle against a rising tide of addiction, mental health issues in our community. And we're talking about ways to combat that in a reactive measure by finding people places to stay, by giving them a safer supply, and so on. But do you see yourselves as having any role in advocating to the provincial government? As Dr. Walmsley said, this is far from a local issue, it's provincial, if not national-wide. A role in advocating to the provincial government to be more proactive with issues or strategies relating to prevention and treatment, rather than trying to deal with this, as I say, rising tide of downstream horrible effects. Maybe that's not your job, but you see the effects, and you must have an opinion, and it's a professional opinion. So I would really appreciate if there's been any thought to that, or what you can do. Do you see it as a role?
My professional opinion is that our efforts, if they're siloed and if they're just our efforts, we're going to get nowhere. It needs to be a fulsome community response. This is a huge crisis on multi-levels. And in terms of addressing social determinants of health, children who are raised in poverty, experiencing intergenerational violence, we have significant social issues, and they're at the forefront here in our community. So we're a piece. Health is a piece of the puzzle, and absolutely willing to be part of the solution. But I think it's really important that we look at, as a community, as a society, how are we going to come together, and who's going to support us to come together and start addressing the needs of our community in a bit of a different way. I don't know if that answers your question.
Well, somewhat, and again, I appreciate your efforts to answer, and I don't want you to put you politically in a tough spot, but I guess my question was more, do you see any role of Violent Health or yourselves in saying to the government, look, here's what's happening, the direction we're going in doesn't seem to be working, is there another strategy that we should be looking at? Is that part of your role or not?
Yeah, it sure is. And maybe I'll let Dana speak to that, because she would sit at those ministry tables.
Thanks, Amanda, and thank you to everyone who is responding and for the very thoughtful questions. Yeah, provincially, in all aspects of government discussions, we are tackling this very, very difficult and complex problem, and early intervention and prevention is absolutely key. We are advocating fiercely for education in the school systems in order to support mental health and needs of children and youth that are coming up through the system and are struggling, as well as being able to capture health services for young children and youth in settings that, essentially has a large net that captures people, where we're developing wellness centers within high school settings so that there is availability of counseling and treatment resources. I think there is a lot of work that needs to be done in terms of being able to provide very sort of complex and specialty services for children and youth. I think that is a major issue that is being looked at between the Ministry of Children and Families, as well as the Child and Youth Mental Health Services within the Island Health realm of service delivery. But absolutely, I can 100% confirm that those discussions are happening, and that there is not one person that doesn't believe in the need for greater services to promote that prevention and early intervention.
Well, thank you very much. That's a good answer, and I'm really pleased to hear that that's acknowledged, because in my opinion, the more work we can do in terms of prevention and education and treatment options, the better off we'll all be. Thank you very much.
Going now to Councillor Gesselbrecht.
Thanks, Chair. I don't know if I missed the slide, but in terms of the comparison, it was like 198 per 100,000 our rate in the Nanaimo area, and that was compared to 2.7 times more deaths than other places. Was that just compared to other locations on Vancouver Island? I'm curious just sort of what the Vancouver numbers were, or if there's any other hotspots in the province that are numbers that are at all comparable to ours, or is that our numbers this high province-wide? And also, I don't know if you have any comparisons to even other locations in Canada that have similar high numbers.
Yeah, so I believe this was the slide here you might have been looking at, with the 2.7 times higher in Nanaimo in the 25 to 44 year age group. So this is, in this slide, I think you might have mentioned, it is only compared to other regions across the island. With regards to the rest of the province, I don't have it at the tip of my tongue, but Nanaimo certainly is sticking out as an outlier with some of the data across the province as well. And I can certainly get back to you, but I know in the most recent coroner's report that that was something that was noticed and discussed.
Great, thank you. Just another question. Are we seeing a larger entry of people into the addiction cycle, and an increase, like, just looking at the 25 to 44 age range that has gone up significantly and is significantly higher? Are we seeing new people entering into this situation that are dying, and an increase in that?
I think what your question is are some of these people who are new to substance use, perhaps?
Yeah, I guess, like, my question is sort of, say, the flow of people that are in this addiction, homelessness, or addiction cycle that are dying. Are we seeing an increase in numbers entering into it and thus dying? Like the upstream, our efforts in upstream prevention are having less of an effect.
Yeah, so Dr. Walmsley was just letting me know here as well, something that the number of first-time users has increased. And so I think some of the things that we noticed is, particularly, I mentioned earlier, they were maybe at the older end of adolescence, but certainly for people who might have been in the university age group, a time when being out and being in connections with others was really important. People lost a number of years of that type of connection. And Dr. Walmsley speaking to, like, connection is prevention. I think we don't have the tracking of, in these numbers of who amongst these numbers are first-time users, but we certainly are seeing increased first-time users. So that is playing a factor in some of what is being seen.
Interesting. Oh, thank you. Yeah, no, there was a CBC article that was circulating, or maybe Globe and Mail, but about a doctor that had some teenage kids, and they're seeing a spike in opioid use, and they were looking at sort of, like, I guess, sort of the safe supply that was being provided, then being sold on the street, and then ending up, being sold to in high schools. I forget what they're called, Phillies or something like that. but there was a dramatic increase in what the addiction counselors were seeing with kids that were using these and not even knowing that they were opioids. They're just sort of like at parties and that. And I'm curious if we've been seeing that play out at all in these numbers and help, looking at explaining sort of the spike in sort of that younger age cohort. I mean, it goes from 25 to 44, which is a little bit older than high school. Yeah, just any comment on that?
There is anecdotal reports all the time. Some of my primary care colleagues will tell me about teenage individuals that have gotten a hold of hydromorphone. The only saving grace is that the hydromorphone itself is not killing them. It only really leads to death, of course, if they start using illicit street supply. I think there are challenges in many areas that you're talking about. And just to address, I see, and this morning I was in the hospital. I saw a young man who usually does not use illicit supply. He was smoking, he was using some cannabis with some friends. A friend passed him a joint. It ended up as an overdose of fentanyl. He didn't realize down was in the supply. This is not unusual, and we're seeing more first-time users that are succumbing, and that again is related to some of the things that Amanda mentioned in terms of the contaminants that are in the street supply right now that are very hard to reverse. Narcan does not reverse benzos. It does, and we're seeing people even in our detox facility 5 days into their withdrawal, we're needing to treat them differently because it's not the illicit supply of opioids that's causing the problem at this stage of the withdrawal. It's the other contaminants that are coming to the front. So these are really difficult situations to manage, both in a withdrawal facility, on the street, in the homes. We're dealing with unknown contaminants and drugs all the time. I don't know if that answers your question, but perhaps it gives a little bit of perspective.
No, that's great. Thank you. I think that this point that there is this increase in contaminants in the illicit supply, and people are being exposed to them. It's just there's poison that's out there in the community, and the people are coming into contact with it at a higher rate, and figuring out how to address that poison is a very tricky. Tricky nut to crack. So thank you for the presentation. That was helpful.
Can I just say one other thing that addresses Mayor Krog's question earlier on? When people have what we're seeing as anoxic brain injury post fentanyl overdoses and repeated drug overdoses, it is a real challenge to get them supports. I have in several occasions tried to look and see what the resources are in this community to give people who have brain injury support, whether it's in the community setting or whether it's in a facility. There's not the resources there. And I would love to be able to refer some of these individuals to an agency, to a facility that would be able to provide greater supports. It's just not there.
I have a question before going to Councillor Manley again. Are we aware of any deaths attributable to people accessing the safer supply?
Yeah, my boss, Dr. Reka Gustafson, who was our Chief Medical Health Officer with Island Health and is overseeing, as Dr. Walmsley was sharing about the bringing under of the drug poisoning response into population and public health. I know she had given a presentation recently at a addictions conference in Victoria, and in that slide deck was sharing that by and large, what has been seen is that it's not the safe drug supply that is causing deaths, it's the poisoned drug supply.
So when you say by and large, I'm just wondering, do we have any data that actually attributes any overdose deaths to safer supply?
I mean, definitively, no. And I mean, it is difficult to track when you have a deceased person in terms of what might be going on. Sometimes there is testing of the substance that might be found on site, and we get information about that. We do have information from when people test at things such as overdose prevention sites, but I mean, it is largely when we see that it's been contaminated drug supply.
Thank you. And just for clarification, when people are accessing an overdose prevention site, my understanding is that they are bringing their own drugs with them. There's no drugs available for people to access at the OPS. That's correct. I'm hearing that's correct. Okay. We did manage to open one warming center so far this year, thanks to Risebridge for doing that. They've been struggling so far. They've had 13 overdose instances that their staff have had to address, and I'm just wondering, is there any supports coming from Island Health to help us and to help their staff be able to deal with the number of overdoses that they're experiencing there? Is there any kind of support that Island Health can offer us when the city's supporting these warming centers?
Dana, did you want to answer that one?
Thank you for the question. Yes, we are actively working with the city in terms of how we can support the various not-for-profits that are operating warming centers and overnight shelters such as Risebridge. As well, I know that Amanda and her outreach teams have been connecting in with Risebridge on a more regular basis and setting up some specific times and expectations around when the teams will be available and able to support on site. We are also have activated our regional harm reduction teams through the Population Public Health stream, and they will be providing advanced harm reduction, advanced overdose response to the team at Risebridge, as well as harm reduction supplies going forward. I think there will be more announcements in terms of how Island Health will partner with the city, but I'm not able to speak to that at this time.
Thank you, appreciate that, and look forward to that information coming forward. I have Councillors Manley, Armstrong, and Perino, and if we can limit it to one, max another follow-up question, then we do need to move on from this topic, and thank you to our presenters for your stamina.
Okay, thank you, Chair. Yeah, so I'm familiar with that whole addiction, social connection, Bruce Alexander's experiments with rat parks. That's a decades-old study in the Housing First approach, and I'm just wondering if anybody would comment on some of the other models we're seeing in other countries, like the Portugal model, and whether that's something that we should be implementing here in Canada and British Columbia in particular.
I think we've tried to educate ourselves on some of the other models that are available in different countries. I think there are a number of challenges with trying to get those things going. It's a collective response. It's not something we can do on our own. In terms of my work within the addiction medicine world, are trying to work feverishly with any of the other community peoples and representatives to try and give greater supports and come up with a better plan. I don't think that we have the resources at the moment to do just what is being recommended in either Portugal, Sweden, or Switzerland, excuse me. But we certainly are trying to look at every model we can to see what works, what doesn't work.
It's really in the hands of the provincial and federal government to take those kind of challenges on in that.
I think,
policy.
and I think Amanda just mentioned this too. I do think that we have an opportunity locally to just be more community-minded and community-focused in terms of what we can get going. It's one of my major issues, and I've been pushing this for a little while to try and collectively get our not-for-profits, our city, our special projects office, to come together in ways that we haven't quite done yet to see what we can tackle. We had one community gathering a while ago where we had, our bylaw officers, our addiction medicine, our peer supports, our various people come together just as a collective to see. And I think there's further opportunity there. I'd very much like to work on that.
Okay, thank you.
Councillor Armstrong.
Thank you. Just a couple points. One was on you talk about the youth. I sit on the board of the Alano Club, and the increase we've seen in youth in our program is unbelievable. And they all tell us they started with hydromorphone that they got on the streets from Safe Supply. So that is a concern. It is really out there, and You're more than welcome to come and talk to some of them because they will talk to you and tell you exactly what's going on. I also spoke with Adam Zevo when he was here and did his, and I know there's people that went and talked to the kids, and they'll tell you that's where they're starting, is with the hydromorphone from the streets. And then, as you know, with most drug users, then it progresses, right? To get the better high, you keep chasing the better high. So it's out there. And I am a believer in safe consumption sites. Where my issue comes in, and this is what I think when you talk about you want to get the community involved, but when the community is feeling the impacts of these sites through increased crime, social disorder, assaults, it's very hard for us to sell this to them because they don't feel safe. And we're so concerned, and I hear this a lot, we're so concerned about those 600 people, but what about the other 600 people who now have trauma because of what they've witnessed, PTSD that some of our homeowners are experiencing? Their empathy and their compassion is going because they feel they're paying for all this and they're getting nothing back in return. I think that's something we really have to work on. Like I said, I do believe in the safe consumption sites. London, Ontario's got a great model where you can't use unless you go into the clinical site, and you're not allowed to leave until you've come off your high, because what happens, you know, and I saw this a lot when I was policing, when people are high, they're not, you know, we can see them do a lot of horrific stuff and some terrible stuff to themselves. So people are witnessing this and they don't like it. So I think that's part of the model. We look at what's happening with the Redfish Healing Center, which is supposed to be top of the line. 4 police officers assigned there a day. And the cost to the community is very expensive and they don't like it. And I believe one of their doctors there has even said they want to have secure, complex care in there. So, I mean, that goes a little bit different to what you said, Dr. Walmsley, but they're saying it's not working. So I think we have to experiment with all these different things. Like Portugal's model, they say it's no longer working. If you look at the newest research, their social disorders through the roof. They're asking for criminalization again. So, and I'm really pleased to hear that you guys are doing the advocacy in the schools, because it shouldn't be the police. I've never believed the police should be doing the harm reduction. They have a role to play, but it should be health experts that can talk about it. It should be previous users who kids really listen to. And I don't know why we're not doing that. I think we put all of our dollars into harm reduction and forgot about everything else, which is leading us towards this. So very thankful that you're doing that. But my final point is, you know, it goes to the question that was asked. What is Island Health doing to financially help places like Risebridge, Island Crisis Care? Because as a city, I mean, we're getting tapped out. We're taking heat from our taxpayers. We're at an 8% tax increase, and they don't feel that they benefit from it. And they certainly don't feel like when you have seniors that can't get their prescriptions and they see people getting illicit drugs, they're very upset. So those are what we're facing. So if you've got some solutions for us, it'd be great, or some ideas.
Just giving Dan an opportunity in terms of discussing monetary arrangements and things like that. I don't think I could at this venue, but like Dana said, I think there is some work going on behind the scenes. Yeah. And I think it's important to note that, like, I'm a taxpayer in this community as well. I was a homeowner for 13 years in the downtown area. I have my immediate family owns a business downtown. So I don't think anybody is saying this is wonderful. And I think it's important that we all look at this together. It does impact all of us. It impacts our children. I'm raising children in this community as well. So I think in order to support our community, we need to understand and show some maybe grace and compassion where we can. And yeah, I think it's just difficult. If somebody, like you said, if a country had the solution, we'd all be doing that. So if we can get creative in Nanaimo and really work together, maybe we can make some changes.
You won't like my answer, but
okay, well, and we can learn from all of those things, right?
Councillor Perino.
Thank you. Just some final thoughts. Thank you, Chair.
Is it a question?
Yeah, Risebridge is doing incredible work, and yet you can imagine with what they've had to go through with their warming center with the neighborhood. So now, of course, we've got other warming centers opening up, and what those neighborhoods are going to go through, and that's the real struggle for us. But you know, Mayor Krogh talked about the involuntary care for those who are the most sick and most brain damaged from the illicit drug use, and the obvious, you know, bringing back. But there's also the other part of the addiction crisis that I don't think we have the centers where people can go for rehab. And that concerns me because when people go in for 3 months, it's not nearly enough time. And I think if we're going to focus on involuntary care for those who are the most sick, we also need to have more facility and longer term rehab care for people so that they can get out of it and get well. We can do, we're working on the housing issue and that kind of thing, but if we can do that, I think that would be helpful. And I just wondered how you felt about that part.
I think as you know, there's a new addictions facility that is hopefully going, or a treatment facility that's going up in the Parksville area, if we can get it.
Yes.
If it gets approved down the next few levels. We're always looking for options for further enhanced treatment. We have increased, as Dana can speak to, we've increased our allocations at the local facilities, both publicly funded, that is, at Cedars and at Edgewood. It's not a straightforward line between going to treatment and cure.
Yeah.
There is no easy answer. There's no simple solution, as we've talked about, and no country has found that.
Okay.
I still think we need to go back to connections. I think we need to try and work. Every day, my work in the community, in the hospital, is to establish a connection with an individual that's struggling. When that individual feels heard, when they feel supported, they sometimes make a change.
I'll just finish up by saying, Dr. Walmsley, thank you for the work that you do, and I saw particularly what you did during COVID with the foundation giving the funding for the vans. So I just want to say thank you, and keep going, please.
Well, thank you for the council for hearing this very difficult question. I think one final comment, Dr. Gustafson said during one of her recent speeches or discussions, COVID really threw a wrench into this. For the longest while, we were telling people not to use alone. COVID comes along, and we have to stay 6 feet apart, and it's the exact opposite of what you want for people who use drugs. So it really threw a big wrench into the whole addiction medicine profile, and I think we are still seeing some of the side effects of that. So I think that's another factor we have to keep in mind.
Thank you very much, Dr. Walmsley, and thank you everyone who presented today. Really appreciate your work and for grounding us in these devastating statistics. Next up, we have a presentation by Dr. Julian Summers, SFU Professor of Health Sciences and Clinical Psychology, to provide a presentation on solutions to addiction, mental health, mental illness, and homelessness. Dr. Julian Summers, please. Oh, you're online. Thank you for being here.
Thank you very much. So I'm here representing a new group, Policy Roundtable on Substance Use Prevention, Education, and Recovery. I'm working in this endeavor with a couple of colleagues, Blair Gibbs, and Kevin Sabat. And Blair, and all three of us have enjoyed and continue to enjoy working together and working in roles providing advice to governments. Blair, probably most impactfully, the government of the UK, and Kevin in the United States, actually a few, well, 3 White Houses, different parties. We're all all three of us are extremely concerned about some gaps in BC's policies and even discrepancies between some of the policies that have been at the forefront in recent years and the available evidence concerning their effectiveness. And in many ways, the policy approach that we're taking in BC has been idiosyncratic and of concern, has been in conflict with what international authorities have advised and recommended. in some ways, those policies, and this will be my presentation to illustrate, those policies are really at odds with the well-being of communities and what municipal governments are responsible for in core ways. Things that include policing and fire, business successes, and community safety and order. And if there are decisions being made that balance provincial and municipal responsibilities, we think that's one area where it's particularly important to have relevant evidence available so that any inadvertent harms to communities, for example, caused by provincial decisions, could be at least identified and potentially averted. I'll start by saying, though, and I enjoyed listening to the previous conversation, that there were, and this is reviewed by the Stanford Lancet Commission, there were substantial numbers of opioid-related deaths attributed to OxyContin. And I hope everybody remembers that era. Dilaudid is more potent than OxyContin. And I think we need to be aware of that fact and not make a across-the-board distinction in terms of lethality between drugs that happen to have been manufactured pharmaceutically and those that were manufactured illicitly. There's a large literature on deaths related to pharmaceuticals of various kinds. So that distinction, I think, needs to be muted to some degree. A point that was made about risk and prevention, I think we have prevention in the title of our organization for an important reason. There's no way to sustain a mortality crisis unless we replace people at the same rate that we're losing them, in fact, at a higher rate. They have to start somewhere. And so the origins of that entry into addiction and toward increased risk is vitally important. And here we are in BC in the 8th year of a declared public health crisis. We have no mature discussion about risk reduction. We might hope that we would be in the fine-tuning stages at this point, this many years in. Unfortunately, that conversation is still nascent. So our group is hoping to provide support to municipalities, to local groups of citizens, in particular in BC. So although we work internationally, our focus is on BC and on providing expertise and information that's nonpartisan, but that is meant to address some of the information needs that in particular municipalities and community groups will have going into the next provincial and federal elections. So we're looking at those cycles. And so my remarks, which I'll proceed into, if I can go to the next slide, are essentially an outline of some of what we're capable of drawing upon that may be relevant. And where I'll end is with basically a standing offer to make ourselves available in the form of providing policy briefings or other more specific focused documents that hopefully are relevant to decisions before council that may relate to how to respond and work with provincial opportunities as they arise. So here goes. Around the province, this segues from some of the mayor's remarks. There is a very critical subgroup of risk that is reflected in the lives of people who are or who are hospitalized for serious mental illnesses, most often schizophrenia or bipolar disorder, also hospitalized for addiction, so on separate occasions. They have multiple periods of incarceration. They receive a certain quantum of social assistance, including hardship funds that are specifically linked to housing. And when we look at people who have all of these criteria, meet all of these criteria, and look at where are they in the BC population, they're, oh, next slide, please. They're all around is the point here. And at this point in time, Nanaimo was not among the communities with more than 100 per 100,000, but would be today if we still had access to these data. I should have mentioned, I started my career in this area at Riverview Hospital in 1986. My clinical mentor was a gentleman named John Higginbottom. John is thankfully still very much with us. And my mentor in addiction was Bruce Alexander, whose name was mentioned earlier. I went from working with Bruce to working with another psychologist named Alan Marlatt. And for about 15 years, we worked on developing harm reduction as a construct and as a form of practice. I've never really strayed too far from that Riverview population, though. At the time I was working there, we were deinstitutionalizing. So we have people around the province in all of these different communities in need of assistance, and in places where we know there is no capacity, either very little or no capacity to support them. Next slide, please. I've had many opportunities to work with groups of people, patients in the Vancouver and the metro area, going through specialized courts, drug treatment court, community court, homeless outreach services. And these data are drawn from one of our studies in which we were conducting randomized controlled trials with people deemed the hardest to house. These are individuals who invariably are experiencing serious mental illness symptoms, most experiencing very active polysubstance addictions. They've been homeless on average for 10 years. And these bullet points, it's a bit of a mashup, but it's meant to illustrate that they have some significant strengths. They have kids that when given the opportunity, they are highly motivated to reconnect with. The vast majority want to resume paid work, having worked for more than 1 year at some point in the past. They're actively suicidal, and there is a significant overlap between suicidal ideation and drug poisoning. More than half of those who survive drug poisonings meet criteria for suicidal ideation at the time of ingesting drugs. And critically, 85% were not in Vancouver when they began their experiences with homelessness, involvement with courts and corrections, and with the worst of their drug addictions. They move, and they move fruitlessly. Nanaimo, it is, I think, not coincidental that Nanaimo's uptick in both homelessness and poisoning mortality coincides with efforts in Vancouver to remove people living in concentrated public settings like Strathcona Park, Crab Park, and also last year, or earlier this year, the clearances along Hastings Street. Those large-scale movements were noticeable, and of course, Nanaimo is a simple ferry ride away from those very settings. Next slide, please. Out of the Shadows at Last is Canada's last, I think, grand self-reflection on mental illness, addiction, and homelessness, and things that syndrome tends to lead to, including extraordinary mortality risk, but also repeated involvements with courts and corrections and first responders generally. Coming out of that work, and we knew even in the 80s that there was a far greater likelihood of quality of life and long-term recovery when people were supported in their communities. And that was the rationale for deinstitutionalization around the world, was the strength of that evidence. It was not done speculatively. What Out of the Shadows at last confirmed for us is that we have very badly failed to follow through in the implementation of what the report Out of the Shadows at last refers to as recovery-oriented, community-based supports. And that's a refrain throughout this very long document, that we need to implement aggressively and across the country as a priority, community-based and recovery-oriented supports. That refrain and that work is important in relation to this randomized trial, this particular one. We've done a few. But the reason being that community-based and recovery-oriented means emphasizing individuals' agency. The opportunity to make decisions is a precursor to being held responsible for our decisions. And so the active ingredient in our trials was the condition rendered on the left. It's market housing. It's housing where not more than 5% of the units in any given building are allocated to our clients. That's done so that there's an assurance of social diversity. Again, this was not speculative. This is essentially what had been successful for both Portugal and Switzerland, which were mentioned earlier, and where a related term was used: social reintegration. So we were implementing this. We did the same intervention in Vancouver, in Winnipeg, Montreal, Toronto, and in Moncton. In Vancouver only, we also randomly assigned people to live all together with a full team on site, about $1.2 million in human resources on site, primary care, nursing station, a formulary lab, vocational supports, all in the same building, the same resources that were supporting the people in the scattered site condition, but where they were providing that support itinerantly. The comparison
Dr.
was
Summers,
usually
thank you. I'm just going to ask that you try to wrap your presentation within the next 5 minutes so that we have fulsome time for questions from council, because we're at the 13-minute mark now. Thank you.
Sorry, I will. Thank you. Next slide. Internationally, the second bullet, 84% of people, this is from a meta-analysis, 84% of people living homeless with mental illnesses have a strong preference for independent housing. Next slide. Here's where we met people. Next slide. Here's where they chose to live. No one chose to live in the same neighborhood where we met them, and we would not have been able to predict where people chose to as their preferred residence. Next slide. We have, you'll have to breeze through this one. Sorry, click, 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 click. I'll jump to the very next slide. This is just sort of a summary. There are a lot of outcome papers from this trial. I would like to get to the next slide, though. Thank you. So one of the findings I breezed past was that the cost to support people in usual care now is about $55,000 while they remain homeless. Recovery-oriented or scattered site housing, this is from administrative data, so court and corrections data, hospital data, and PharmaNet, confirmed that people who got to choose where they lived following this recovery-oriented community-based support had 71% fewer criminal convictions the next year, 45% fewer emergency department visits. They were far more likely to be compliant, adherent, technically, to prescribed medications. None of these changes, none of these improvements were observed in the people who received congregate housing. In that condition, the culture of the building was very much the culture of the street. And the point here is that concentrating people together costs the same as providing scattered accommodations, does not result in the same benefits. I'm gonna go through the next two slides rather quickly. But I want to show that they reveal really in different data sources, thanks to some of my colleagues at NAPSA for providing these. Perhaps it's the next slide that's even more important, and you'll be able to interpret this better than me. But essentially demonstrating the concentration of first responder calls to fatal and non-fatal overdoses around settings of service, settings of risk, and settings where people are likely concentrated. So this is another way of seeing some of the harms of congregating people together. Next slide, please. We had proposed a plan to essentially implement around the province in communities with high evidence of need, services that reflect what has been shown in evidence to be the most helpful to people, that remains available and can be applied to individual communities. Next slide, please. I'm down to my last two. Over several years, we've seen not only this numbing increase in poisonings, particularly among people who are unemployed, but we are already past the point of increasingly detaining people involuntarily, and whether that's involuntarily by admitting them to hospital or by involuntarily incarcerating them. We are using our institutions with greater and greater regularity to involuntarily contain people. A preferred approach, rather than growing that on that practice, might be, and our advice is to dramatically increase the availability of effective voluntary forms of intervention, so that any plans around the growth of deliberate involuntary forms of engaging people would be the residual and not what we lead with. Next slide, please. Some of the work that we've done, in particular looking at decriminalization and work that why were Portugal and Switzerland effective, why was Oregon less so, and why does BC seemingly appear to be less so, are covered in reviews that we've written, and these are some of the off-the-shelf, I guess, materials that we have available to us at Prosper to call upon in our effort to try to be responsive to the types of questions that you may pose. And I'll end there. Thank you for the additional time.
Thank you very much. Questions from Council? Councillor Perino and then Councillor Manley.
Thank you, Chair. Dr. Sumbers, I'm just wondering if I heard you correctly, and Dr. Wamsley said it as well, that connection that people are looking for, that's truly the piece that's missing. And when we provide housing for them, that may be the connection that would help to give more hope as far as their long-term health.
Yes. Yes, that's true. People, however, with deinstitutionalization, we understood that it was important not simply to have people out of an institution, but have them in settings where they had organic connections. And if people are, 25% of the people we've worked with in this hardest to house category were in provincial foster care. 25%. I don't know what fraction of 1% of the BC population was raised in foster care, but there's profound evidence of not only adverse childhood experiences, but an absolute absence of connections. Now, where people have the ability to reestablish connections is critical. And what our work and work across the country and internationally has shown is that the most meaningful connections for people are not with professionals. They're not with people like me and or with other people who've experienced mental illness and drug issues. It's the top qualitative improvement that we heard from the clients that we worked with in the scattered site environment was a normal place to live and experiencing themselves being treated as a normal person. So really they're saying it's their neighbors and the ability to interact as members of a healthy community that was the most responsible for their improvement. So we need to think in places like Nanaimo or the downtown east side and other places where people are living concentrated. Why are they there? It's often because of the support and tolerance and the humanity in the communities that they migrate to. But that doesn't mean that that is necessarily the place where their needs would best be responded to. It may be important to look at where did they come from? Where is their home community? Where are their kids? Where are their family members? And how can we better support them long-term, relocating to those settings with the necessary supports?
And just one more quick question. You heard Mayor Krogh talk about those that have the most severe mental health issues or brain damage from the addiction issues. Your recommendation for them?
There's no question that as each year passes and more people are experiencing resuscitation from Narcan and other forms of closed head injury, that cognitive impairment is changing in the population. But cognitive impairment has been a feature of the population since I entered the field. And one thing that has stood out to me and others is that we sell people short. When we've done our work, I can't tell you the numbers of community meetings where mostly professionals, health professionals say, oh no, you can't plan to put those people in community settings. They need to be in an institution. And that was wrong, but it is a refrain. And it has led me to be wary of that prejudgment and to instead proceed empirically, meaning let's expand. We know we need to expand voluntary options for people that have been shown to be effective and that are in undersupply. Let's grow those aggressively, provide people with the opportunities to exercise choice, to experience support, and let us see through that experience what the residual is. The better the job we do of engaging people voluntarily and the more we practice prevention and early intervention, we should realistically have in mind a point where we no longer have concentrated populations of people who are being resuscitated by Narcan repeatedly.
Yeah.
So rather than my fear would be that we build a setting that essentially is like a downstream trap where we basically count on people falling into the river far upstream, drift down, and now we have an institution that we can involuntarily place them in. That would be the exact opposite of what I think makes the most sense.
Thank you.
Councillor Manley.
Thank you, Chair. Yeah, thank you very much for the presentation. A couple of things. So when you were talking about the street sweeps in the downtown east side and the spike in overdoses here in Nanaimo, do you know if that's been tracked, the number of people that may have been coming over here, or is that just?
I'll tell, like, I've been working with this provincial government and others now since the mid-90s, and this provincial government has really surprised me. It's the first, we were ordered, I gave a presentation similar to the one I gave to provincial deputy ministers, and 1 week later, we were ordered to destroy our entire database. Ordered. Yeah. Didn't matter that people gave us consent to learn from their data. It didn't matter that there were benchmarks that had been established. This amount of crime reduction is possible. This amount of addiction risk is reduction is possible. None of that mattered. So I've become convinced that this provincial government does not want there to be readily accessible information to answer the question you posed. So all I have to go by is the evidence of my senses and other people's senses, recognizing that there were hundreds and even thousands of people living in concentrated settings, and they were swept. Where did they go? Contemporaneously, we see, oh, look, here's a large increase in exactly the same problem one ferry ride away. To me, I think if we had access to the data, but actually, sorry, here I'm telling my story. You, as council, can ask the province for this. People are going into the to get prescriptions filled. They have a provincial identifier. Every year, people register where they were living. How many of the people, the province should be is able to answer this. How many of the people that are receiving prescriptions for Dilaudid or any other addictive drugs in Nanaimo were within the last 5 years registered in some other community?
Yeah, I find it actually, I've seen your video talking about the data, and I find that really shocking. I mean, I just can't see any reason why we would ever trash data and demand that people destroy data, because that's a historic record, and that's the kind of thing we need to be looking at. It sounds like you're very much in favor of the same kind of things that we've heard from VHA, which is 4 pillars, the dispersal model, housing first, and then you get people in a situation where they will take care, they will accept care in a voluntary way. So yeah, I just want to say I appreciate very much that approach, and that's I think what we really need to be working on. It's interesting to hear that you worked with Bruce Alexander, so I take it that you subscribe to some of his thinking in the way of that connection. Clearly, the connection and addiction. If you're feeling connected to the community, you feel like you belong, you're less likely to be into an addiction cycle, especially if you're contributing. And I've seen that anecdotally all over the community. When you get people in a position where they feel like they're helping other people who are less fortunate than them, it really lifts them in a way that's positive. So thank you for your presentation.
Councillor Armstrong.
My pleasure. I stay in touch with Bruce, and we're still looking for a point of disagreement between us. He's been an incredible mentor.
Thank you. I have a couple questions. One is, we hear anecdotally that there's some of the residents are leaving Suboxone and methadone programs in favor of safer supply. Can you speak to that as to what you think? Would that lead to different behaviors? Are there benefits to do that, or?
Yeah, we've done quite a bit of research on opiate agonist therapies in BC, looking at about 14,500 people receiving methadone, Suboxone over multiple years. And fully 1/3 were diagnosed also with either schizophrenia or bipolar disorder. They are in the large majority unemployed, living in substandard housing, and receiving inadequate additional supports. So methadone, which was introduced as a powerfully positive way of engaging people in essentially a really meaningful life transition. This is how methadone got on the map. It's become atrophied to the point where it is essentially a pharmaceutical intervention, and that's the only part of the original, very fulsome intervention that remains. It's not only in BC, it's actually all of North America. So people become, it's not that effective. It does have a small measure of effectiveness, especially when you have large numbers of people, but in a meaningful sense, clinically meaningful sense, it's not that effective. So it's not surprising to see people abandoning that form of support, that element of support, and resuming addictive behaviors. It's clearly a step toward increased harm. It's hard to see it otherwise. And I bemoan this because the problems, the deficiencies relating to methadone as an element of helping people have been so well identified that at a provincial level, I think we need to do much more. There's no excuse for overlooking the fact that most people who are dying are unemployed and have been for several years. So this is getting to the question raised earlier about prevention, and here it's a variation. It's earlier intervention. I'm not sure how to relate this to Nanaimo politics, to be honest, but at a provincial level, we absolutely must and can do more to enhance the overall effectiveness of methadone for people who need it. And we should be transitioning people, I think, as quickly as possible from the streets and high-risk addictions into a much fuller array of voluntary options that would include OAT. I mean, I didn't mention this, our interventions had OAT and even like other forms of prescribing in the background. The key thing was getting people into circumstances where they themselves would experience a life worth living, a life that matters so much that they start to turn their attention to re-engaging with their kids or resuming work. And these, for most people, are the thought processes and means of engagement that explain why we're not out shopping for fentanyl or on the dark web or on the street. We literally have better things to do, and that's something that we can extend far more readily to others.
Okay, and then my second question is, as you know, BC has really gone to the supportive housing model, which I believe has some really good programs. However, my concern is when you have somebody that goes to treatment, like I know a young lady that went to detox, then she's put right back into that supportive housing unit where all the drugs are, all the stuff are. Do you see a place for somebody that wants to get healthy, that's been through detox, I call it second phase housing, where they go into housing where there is no drug use on site and they have supports, but not the 24/7 supports? Like, do you see that role? Like, because I'm always concerned, like, it's like putting an alcoholic into a bar the very first day they decide to get sober. So now we're putting this person back that's done well in detox. We're putting her back into where she's been victimized. There's the drugs are there, whatever. Is there not a role for another type of facility, or not facility, sorry, residence for them?
I think there's, if I could, two parts. I'll try and be quick. One is we have almost no capacity throughout the private landlord market to offer people accommodations where they could choose a unit that's dispersed in amongst other intact buildings with diverse neighbors. That actually should be our norm. A long-term home where people's residence is not defined by being a member of a group that shared a common form of hardship at one point or another. It's not what people choose, and it's not where people do best. In fact, concentrating people together, our results showed concentrating people together causes crime. It causes crime. If that's the model, if that's a model that's being proposed for Nanaimo, great news. We're here to help you. This is the province. We're going to put in a building where everyone's going to be housed together. That unless it is dry housing or some other approach that currently hasn't been discussed, that is making a choice to deliberately increase the amount of crime in the community compared to what's achievable for the same money. But through a different model. I think there is a need. I mentioned 84% choose independent housing from the meta-analysis. So that's not 100%. And there is a need for group housing, but the group housing that we provide right now is not at all standardized. There are no consistent standards in order to match needs among a target client group with the resources that will be provided in that building, and to do that consistently around the province. Nothing like that at all. the way I've been, forced to study some of these proposals for rezoning and outfitting, and essentially the operators are asked to bid on, well, what can you do for this amount? Which is crazy. It's just crazy. It's not the way we do healthcare. It's not the way we do, other things. But here somehow there's this. It's true. This is true also for the landscape of addiction treatment facilities as well. Very eclectic array of standards, little consistency. So I think that increasing scattered market housing options for people, number one, and insisting on standards for the congregate housing that's operated that clearly link patient level needs or person level needs with the resources of the building based on evidence. Those two things I think are fundamentals.
Thank you. I think the Canadian Mental Health Association follows that pretty good, because I know we've got a lot of homes here and there's never any issues with them. Even the one on Rosehill, which has 28 people, you very rarely get issues from that because it's doing exactly what you said. So thank you. I have lots more questions, but I'll stop.
Councillor Thorpe, then Councillor Gesselbrecht.
Thank you very much, Chair, and through you, thank you, Dr. Summers. Very interesting information. I appreciate it. Actually, your reply to Councillor Armstrong just now answered basically the line of questioning that I wanted to put to you, just to make sure that I clearly understood the model you're suggesting. And I come back to three words which you've mentioned more than once, and that is with necessary supports. Because we sometimes think of housing first as an easy solution of taking a bunch of unfortunate people with addiction problems or mental health issues and following what I personally term the Victoria model of putting them together into a motel without necessary supports, where they're not in a healthy environment and in fact are an easy target for criminals and drug dealers. So your model is ideally dispersal into a more healthy environment with some structure in place and the necessary supports to get these people back on track. And I think your answer, as I say to Councillor Armstrong, clarified that, so I won't belabor it, but thank you.
Councillor Gesselbrecht.
We did all of this research. Thank you. I appreciate that. We did all of this research following the model in particular developed by Pathways to Housing in New York, run by a friend and colleague of mine, Sam Sambaris. And Sam referred to the model as Housing First, so we adopted the name. After we published the results from our trials, the Canadian government shifted its housing support envelope to insist that that eligibility for funds would be restricted to programs that followed Housing First. What followed was a bit of a mockery. Programs didn't change what they did. They changed the name of what they did to Housing First, and they continued to access the funds. There was no discernible change in the landscape of supports, and all we did was cheapen the meaning of the term Housing First. It really gets back to providing people with opportunities to become members of communities where the key partners from the street to where they need to go next are networks of employers to work with them around opportunities for supported employment, and networks of landlords in the private market to grow up the body, the portfolio of scattered market housing that's available. Those are the two key things.
It makes a lot of sense to me. Thank you very much.
Councillor Gesselbrecht.
Great, thanks, Chair. To Dr. Summers, I just, in terms of the gulf, I don't know if you've done any research in this area between the amount of investment in HR and housing units that would be required to address the current homelessness population that have co-occurring with drug addiction, between what is being provincially invested at the moment to what is needed. Do you know roughly what that number would be? Because I from what you're saying, the strategy, I mean, maybe we're building a bit higher concentration of people and providing services and housing, but there's just such a sheer gulf between what we're able to, the units we're able to make available with the supports that would be necessary to support people through that and to work towards employment. There seems to be an issue in scale. So do you have any commentary on that in terms of what would be actually necessary to make a dent in this?
The main thing, yeah, so I think the main thing that's necessary is as leadership with the courage to spend differently. That's the main thing. Spend differently. So rather than flowing all the housing dollars through BC Housing into not-for-profits, begin allocating some of those funds into securing long-term units in the private market. If you look at the increases in spending, so the death and suffering is what I pay the most attention to. But if you look at the program areas of increased expense, that traverses and it overlaps with burden on people, of course, but it traverses police and fire. It traverses business and businesses thriving. It also includes costs related to everything from emergency shelters to soil remediation in encampment settings. We've got a vast array of costs that we are incurring right now. And at the core of it, from our research and other people's research, the core component that is narrowly related to housing and support does not compare well with what we would be generating in terms of outcomes if we spent the same amount of money differently. But if we spend it differently, we then are relieved of the repeated hospitalizations, the repeated arrests and periods of incarceration, and then the costs that go with those activities. So I think if we just look at the cost of things we can count, people living on the street versus living in scattered site supported housing, that's a wash. The econometric analyses have been published several times showing that. But the status quo has these additional costs associated with it, let alone the growth of bureaucracies that account for most of the job growth in BC over the last few years, many of which are concentrated on these human service activities. So I think from the available evidence, I would say it's a wash. In BC, I would say it's reasonable to expect that the overall cost, municipally, provincially, et cetera, would be lower if we implemented effective, evidence-informed approaches. But the thing that I feel like I've butted up against in my own advocacy is there was not, this is prior to the implosion at BC Housing, but there was not any willingness to alter how funds flow at the provincial level through established coffers. That has to change.
So just for clarification then, so say for example, instead of building a 40-unit supportive housing or 50-unit supportive housing complex in town, that money would flow towards, say for example, identifying basement suites or a single family home or a quadruplex, and then taking that housing out of the private market and being like, this is going to be a BC supported recovery unit, and finding, say, for one supportive housing unit would be 40 units, finding 40 units scattered across the town for that, and then providing services for those in terms of healthcare and employment services. Is that correct?
Yes. Key is assuming that all those people that you're aiming to support in Nanaimo are best supported in Nanaimo, and not in Surrey or Kelowna or some other place where their problems may have originated and where they may have greater strengths. If I'm a council member, I would say I would be asking for both. I'd be saying, you know what, we have a housing shortage, so I want the 40-unit building. I want 2 of those units to be reserved for so my 5% rule, to be reserved for people that we would help exit the streets. But I want 38 more units scattered throughout the existing holdings to do exactly the same thing. So I'd basically be asking for both. But yeah, your articulation of what I'm getting at is accurate. It is a false economy from our evidence, and it's also not what people choose. How, you know, if there were 2 buildings, each with 1 unit, one building is exclusively made up of people who've been homeless, experienced mental illnesses, many have drug problems, and there's another building with a diverse mix of people from the community. And which building would we choose? Most people choosing the diverse building. Why would we expect people with addictions and mental illnesses to choose differently? And when we give them choices, they don't. You saw my map. They choose where, you know.
Dr. Summers, I think Councilor
one more follow-up
Sure.
question. Just in terms of, I think stigma is a huge barrier as well, and I guess sort of like the model of scattered housing and placement. Say, for example, if like a basement suite, or for example, a single family home within a particular neighborhood, for somebody that's like in that acute stage of addiction where they're requiring some serious intervention and stabilization, would be going into that scatter site immediately be what you're speaking of, or not so much be sort of stabilization? And I guess
that's
would there be
what
barriers?
we found.
Would there be barriers around stigmatization and just pushback, I guess, like even larger than what we're experiencing in Nanaimo around just the supportive housing units, having it even more integrated into the community?
No, we didn't experience that in any of the cities across the country. That's not what Portugal or Switzerland experienced either. Remember, people experience mental illnesses and drug addictions in the housed population, though there are far more people housed with these problems than the unhoused. When we talk to landlords about this, none of them are, you know, they're not looking at us thinking, oh goodness, you're talking about introducing addiction into my building. They already have people with addictions in their buildings. So the stigmatizing view, as I see it, is looking at people who happen to be homeless and struggling with these challenges and saying that they need something different than what we would otherwise make available to anyone else. That's stigma, putting them all in one building together versus providing them with the opportunity to thrive as members of our community like anyone else.
Great. No, that's great. Thank you.
Thank you. Councillor Armstrong.
My last question. I was just wondering if you felt if decriminalization has contributed to the increase in overdoses.
Unfortunately, yes. There's no reason to believe that. I mean, the Stanford Lancet Commission covers this. We discuss it in our review on decriminalization internationally, but there's no reason to believe that reducing stigma around drug use, reducing sanctions relating to drug use, or increasing the overall supply of drugs in a population is going to result in any improvement in the absence of other substantial changes. And that's now been most recently replicated in Oregon. But you know, Portugal's experience, the reversal was mentioned recently. That really started in 2010. Their overall spending, the budget for national addiction dissuasion commissions and social reintegration was cut 83%. And so there's really not a surprise that the effectiveness of what they were doing between 2000 and 2010 has been eroded. Fortunately, they're revamping their approach, but they would tell you themselves. My colleague João Goulot, who's run the national body in Portugal, he said this on the record many times. If all we did was decriminalize drugs, we would have made things worse.
Thank you.
Thank you. Seeing no further questions from council, thank you, Dr. Summers, for your presentation. We are going to take a 10-minute break now, and then we'll come back for our presentation from the Nanaimo Community Action Team. Welcome back, everyone, to today's GPC. We're continuing on with our presentations. Next up, we have the Nanaimo Community Action Team. Joining us online today, Serena Claver, Coordinator, and Key Sepulveda, our peer coordinator with the Nanaimo Community Action Team, to provide a presentation on the work of the Nanaimo Community Action Team. Thank you for joining us today.
Thank you. This is Serena Claver here, the Nanaimo CAT coordinator. I don't have the privilege to start my video, so I am unfortunately my name. But I do want to thank you for allowing. Oh, I can start my video now. Wonderful. Here we go. This is what I look like. Good afternoon, everyone. First, I want to just take a moment to say thank you for letting Key and I be present and be participating in this conversation today. I think it was very poignant hearing the previous conversations that we had today and the other conversations and experiences that we're all navigating through right now in community. So although the presentations were heartbreaking and hard to sit in, you know, this is a continuous dialogue that we need to have. So I'm going to try and do the community justice in trying to dialogue and share what we feel is important to share and figure out paths forward of further building rapport and relationship, and how do we continue this dialogue so we're actually implementing and impacting some collective change. So my name is Serena Claver, as I was introduced. I'm the Nanaimo CAT coordinator. I'll let Key introduce themselves later on. Key is our peer coordinator, so we work part-time coordinating the CAT. I do want to acknowledge before I go into kind of the structure of the CAT, and I'm fairly certain all of you have seen and heard and discussed the CAT before, but what I've come to learn, I've only been in this position for about 6 months now, that there still is a lot of confusion about what the CAT is and how the CAT needs to and wants to work in community. But before I go into that, I just want to express that I'm grateful personally to be able to be present and coordinate on behalf of the CAT, you know, on the traditional unceded territory of Nanaimo First Nation, and that the Nanaimo CAT is very aware of the disproportionate ways in which Indigenous communities are impacted by the toxic drug crisis across the island. And we are really authentically trying to reconcile how to learn and change this. Just a little bit of background. I'm a professional community planner. I actually currently work in municipal planning with another municipality, Campbell River. So I actually work with the CAT coordinator there. So I was trying to find a creative solution of figuring out, you know, being in that role there and how does that link up with the efforts being done with the CAT here, and can I find a way to kind of fuse some of that knowledge together. So yeah, there's been a lot of learning in the last 6 months. There's definitely differences, unique characteristics about each community as we're learning through the data that we were discussing earlier today. However, there are definitely parallels and a lot to kind of take and learn from. So I'd just like to ask for the next slide, please. And we could transition to the next one after that. Thank you. Just for a reminder, the CATs were established in 2016, or at least that's when we started establishing CATs across the province. There's now 36, Nanaimo being one of them, and Nanaimo was one of the first. So really the main intents are for the CAT to come collectively as a community in response to the overdose crisis. And, you know, it states breaking down silos. We talk about collaboration all the time. Really to be all representation of community, and also to be that conduit of on the ground supporting community, but also connections and relationships with other levels of government. So I'd like us to transition to the next slide, please. So this is a borrowed slide. This is from Camel River's CAT, but essentially it emulates the functionality of the CAT here as well. So it just shows you the relationship with other levels of government. The differences being that the CAT in this year and in years next year to come as well, we receive $80,000 versus $60,000 for Camel River. There's obviously a population difference. And locally, the Nanaimo Brain Injury Society is the funding holder. So essentially we're reporting through that agency, but ultimately we work collectively as a group to figure out what the priorities are, but we do need to meet CAIBC's reporting requirements. I'd like to ask that we move to the next slide, please. So essentially this just is a reminder of what functionalities and where the focuses are for CATs. So we have peer empowerment, because as we're learning and we've seen, Key and I were just present at the CAIBC convention or convening just about a month ago with all CATs across the province. We need to be peer-centered. It is demonstrate in other communities that are more successful than we are here. So that is definitely something that is a priority now and into the future. Cultural safety and humility, these are our values. Social stabilization, we've talked about connection in length today. That is key. And addressing stigma and discrimination of human rights. These are things that we don't need to rationalize. We know are important and they are our priorities. We also have some core interventions, which I've got listed. So naloxone access, I don't need to read those all out, but those are what the CATs function and focus on. And if we can go into the next slide. Thank you. So specific to Nanaimo, we've got not-for-profits, we've got on-the-ground service providers, government agencies, healthcare providers, including Island Health, community members, people that have been touched, which is just about everybody, and people with lived and living experience. We need to all be represented, and we all need to have voices collectively. So this is varying different agencies, but ultimately we all care, we're all trying really hard, and we're all trying to work better together. And I think the conversations that in the previous presentations today emulate the conversations that we'd love to bring forward into the CAT and keep dialoguing about, because there were some big questions being asked. We didn't have obviously answers to all of them, but these are the type of dialogues that we're having on a regular basis. We were, Key was present at Risebridge today. We had a conversation with Sheila Malcolmson last week, trying to figure out how to respond to the challenges that we're seeing in that neighborhood right now. If I can ask to go to the next slide, please. These are some more specific projects. So I did mention that there's CAIBC reporting requirements. So there are, initiatives that we're trying to allocate those funds towards. One being the Overdose Awareness Day. We know that campaigning and driving awareness and trying to break down stigma in community is absolute. We're trying to triage, but we're also trying to look into the future and do some long-range kind of planning. I guess that's the mentality that I adopt being a planner. So these are some campaigns. We do have some anti-stigma dialogue sessions that we're continuing next year. with the broader community, because that was highlighted as a need, and it was researched, and it's not something that needs to be proven. We know that we need to do it, as much as we're constantly trying to respond to the number of increasing deaths and overdoses in community at the same time. Key can speak more to this later on, but we also work directly with peers in community, trying to understand and support them better to the best of our capacity, which includes employment. And so that's, we do offer stipends so they feel like they're able to contribute, because they have a lot to contribute, no more or less than myself. We have our monthly meetings where we bring all the different representation of community together. And this will be the continual ask is how do we better forge relationship with city council and staff, because we don't have consistent dialogue, and that we know from other best practices across other CATs across the province that it is a proven need. So if our monthly meetings aren't the right avenue, we need to figure out how to continue this dialogue building off of today. And then advocacy, that was brought up by someone earlier about advocating to other levels of government, and that is something that we strive to do and are continuously making efforts to do. Next slide, please. I don't want to have to rationalize why the CAT is important. We know that Nanaimo is in a desperate crisis right now, and so bringing all the different representation together and trying to work through these very, very complex questions and actually take, I don't want to say decades, research and work that's been done for a very long time, and actually try and respond to where things are at today and where they need to continuously go, because obviously things need to be changed, and it's just a matter of how we take all the different plans and initiatives and strategies we have, and how do we actually start implementing them more. So that's a never-ending question, but coming together and working together, I think we all know that how important that is. Next slide, please. So there is, I'm just going to ask if we just go through these slides pretty quickly, probably to the last data, because we've talked through this already, and I don't want to be redundant. So I do appreciate that we did have that presentation earlier today. Just the very last one. Because I think, just because there was an ask about comparison across province of numbers, and these are just totals over the last decade. And so obviously there are higher numbers in other communities in the province, but then we have to compare that to population size. So Nanaimo, we know, has some of the highest numbers for population size. So just wanted to bring that, and we can move on to the next slide, please. So really, this is more an opportunity for Key, if Key feels they have the capacity to share more. And I really, I'm not here to give, a high level superficial conversation or demonstrate that, but ultimately, just kind of trying to condense time. But the biggest thing is, it's abundant and very apparent that we have a significant issue in Nanaimo. And our biggest ask is, and I would like to dialogue more about it, is how we can just come together a little bit more consistently and work through this, because as much as certain jurisdictions are the way that they are, and they do create barriers and they do create responsibilities, and I recognize and I completely honor the fact that there's financial constraints, but finding ways to take what we know and implement it on the ground are things that the CAT are trying to do. You know, we're trying to brainstorm every month or every week, or if we have to triage every day, which is happening, we do need to have a better link with each of you today and with staff, so that we're not constantly going in different directions or doing or making efforts that are actually counterbalancing and working against one another. So we're trying to, you know, find language that is impactful and kind of resonates in the right way. And some of the research that we've been looking at speaks more from around collective impact versus collaboration. And really, ultimately, they are very similar, but essentially, we're all just trying to work together and where we actually see some change taking form. So, Key, I'm not too sure if you wanted to speak. I know that it's been a very difficult while, just responding in community. So I'm grateful that you're here. But yeah, I allow you to speak if you want. I will be open to questions afterwards.
Hopefully everyone can hear me, and hopefully I can keep it brief and not get off track. Yeah, I guess when we're talking about peer-centered collective impact, what we're really talking about is an empowerment approach to trying to heal this the grief and the sorrow and what is constantly described by peers as the suffering in community for people who are connected to the toxic drug crisis. So we're not just talking about policy and those kind of changes. We're talking about the changes that we can make every day in each other's lives, and collective impact implies a deliberative democracy and in everyone having a seat at that table, and that includes our city council members and our RCMP, our EMS, our firefighters. And the CAT, when it was founded, did have a strong presence of all of those members that has unfortunately trickled off throughout the years. And I believe, based off of what we see from CATs across other places in British Columbia, that we can gain a lot from bringing in your voices again. We do go through a peer-centered approach, so peers are at the heart of the work that we do, and we empower them and we employ them, and we create initiatives to try to further that support to be more than just stipends and honorariums. We try to make it something that can stabilize an individual. I can speak for myself that I am the peer coordinator of the CAT. I am someone who is in recovery from drug use, and it is the CAT and other agencies that stabilized me, that got me to a place where I could do this work. And I find that within peer-centered work, really what it is it's an infinite pool of renewal of support. So you rise an individual to a place where they are safe and stable, and they will always return that. And I have never met anyone who hasn't, given the clothes off their back, whatever it is that they had that someone didn't because they were given it when they needed it. So that's what we try to do. And although that is where we center our work, that seems very humble, that's not to say that more bureaucratic processes don't have a seat here. They definitely do. We have lots of organizations with their own policies and procedures that sit at our tables and have conversations with us and work on not only emergency response initiatives like the one that the CAT has put together with RiseBridge for the warming shelter this week, but also in preemptive work, in stuff that is working ahead of the expectation of an impact in community. And we can see with the CAT team in Cathette that they work very closely. Their fund holder, I believe, is actually the city of Cathett. And so with their city council, on their side, the amazing things they've been able to do, they founded a Zumba, which was a bus. It's a bus that goes around and is a free bus, and it picks you up if you need a doctor's appointment. And then that was the biggest issue they had, was in their little community. Homeless people, drug users on the street were unable to get access to their appointments to get the medications that they needed. And so they were able to fund these initiatives because they had such a streamlined approach, because the city has such a wide scope, right? And we saw the same thing in the Cowichan Valley with their village, their homeless village. That they put together during COVID, which was phenomenal. They did all of that with the support of the RCMP, who again were able to streamline support. And in Surrey with the fire department, who were becoming the first responders and the harm reduction workers for overdose. We saw them working with their community action team to not only help support training and peer support for these firefighters on scene, but also to help these firefighters in dealing with the trauma that they were now experiencing that wasn't a part of their job previously. And this is something that I do know is happening right now in our community, is our firefighters are frustrated and overworked and responding to overdoses, and it would be amazing to have those people at our table so that we can collectively decide, how do we support each other, because no one person can do this work. So yeah, I hope that wasn't just kind of rambling. I hope that made kind of my point across. But yeah, when we say peer-centered collective impact, what we're really talking about is just bringing everyone to the table that could be there. And bringing yourselves as human beings, and understanding that we all have so much to give, whether we're a politician or a firefighter or just a peer person in community, whether we know someone who's lost someone or we've lost someone ourselves, we have something to add to this crisis that can be a solution. And we don't have the solutions, but we can work towards a solution together. And yeah, I hope that was.
Thank you.
I think I'm just rambling.
And Serena, I do believe we have some questions from council. Did you have a final slide that you wanted to touch on before we move on to questions?
We do have one final slide. It's just a reminder of when we connect, but ultimately, that's really it.
Okay, thank you. Mayor Krogh.
Thank you very much, Chair, and thank you very much to both of you for the work you do. I appreciate it's probably the most challenging work in the community, and you work side by side with a bunch of other folks who are facing the challenge with the same compassion and energy. Mine's a fairly simple question in the sense that it just asks for an opinion. If our toxic drug deaths are 2.7 times higher than the rest of the island, do you have any opinion as to why that's the case here?
I can happily start. I first want to remind everyone I'm not the most intelligent person in the room, but I do come from a planning background where my focus has been on health and resiliency, and I've been trying to put that to application for quite a few years now. I worked on in partnership with Canadian Mental Health Association over 2 years ago on integrated coordinated access, where we did substantial research around health and homelessness. I know that the data existed then, that Nanaimo had the largest numbers across Canada for the unhoused population. There's a lot of contributing health factors. I'm also well aware of just the fragmentation of systems in our community, and that is, that is a priority for the CAT, for us coming together. I can't speak on supply on that because that's just not my area of knowledge and expertise. But that's really where I see it is. I know that there isn't enough housing. We know the pit count numbers. We've been trying to strive to have more housing in the community. It's also the right type of housing. We've heard that, and I know I don't want to be redundant, but I know that. I saw it. I saw the data. We were trying to put that to practice years ago. It's a functionality of the work that I do day in and day out. I know for myself and all the studies that I've done around health that everyone needs shelter and a place to land. Think of when you're in your most stressful day, what is the one thing that you want to go do? You want to go home in a quiet, safe, comfortable place. Well, if you don't have that, how do you even deal with the stresses of your day, let alone any sort of health challenges that you may have or unhealed trauma? So, that doesn't need to be proven anymore. It's just we're trying to figure out how to actually implement that and make it so it's accessible and appropriate and really does meet the needs of community members. So I won't go on any more of a rant. I'll let Key, you please voice your thoughts and opinions.
So my work mostly involves working with our peers in the community. So whether that's through outreach or through our peer advisory committees, where we meet monthly to discuss what is going on in our community. And we gain a lot of insight from these meetings. Something that is said time and time again is just that there is a lack of services. And that's not for a lack of the services that are available trying. I believe they are trying. We're all trying, but lack of funding, lack of capacity, even just when we talk about what has the CAT done in the last week, we had to put together in 4 days an emergency response to the warming shelter, in which we had to get peer support workers in there immediately to start responding to the overdose that was the amount of overdoses that were taking place there. So and that's that is what we're hearing, is that services like RiseBridge, they managed to break through the barrier of funding, but did they break through the barrier of being able to fund employees? And then if they have the employees, then do they have the funding? And it's a constant struggle to try to do this balancing act in community, and then also balance all of the rules and regulations that come around with working in this work, as the conversation with RiseBridge took place. There are lots. There are easy ways to get rid of people by banning them from services, but eventually they will be banned from all of the services. So where do they go? And when we're talking about people with brain injuries, with complex care issues, we're talking about people who can't show up and behave, quote unquote, appropriately. And what services do they access? So that's what we hear most at our meetings, is that there's not enough services and the services are not adequate enough, but that the people who are accessing these services, people who use drugs, are saying that they don't necessarily blame the service. They blame a system that is abandoning these services to have to continue to fight for funding and try to build capacity where they don't have it. And the CAT is trying to see these gaps and glue them together the best that we can with what we have, and it's not enough, is what we hear. It's not enough, and the approach is not enough. The approach is not peer friendly. It doesn't bring in a sense of welcome for someone who doesn't, or who may look like what people think a drug user looks like. So even if staff are friendly, there is still a barrier for accessing that service, even if this service is available at the right time. So that's mostly what we hear, is that there's a lot of training and there's a lot of gaps that need to be filled within shelter services, housing services, harm reduction services. And then we hear from those agencies themselves, oh yes, we have these gaps and these training needs, absolutely. And then as well as that, we hear that we need training and conversation. We need a sense of community with police, with firefighters, with EMS. We need to know each other. In my work, you walk down the street and you know everyone. And it would be impossible for me to do my work if I didn't know the names of everyone I'm walking by every day and saying good morning to and giving a cup of coffee to. And I wish that we had that same relationship with our city council and our RCMP and our firefighters, because in that way we could protect each other, not just support people who need access to these services, but support the people who are experiencing trauma from delivering these services.
Thank you very much, Key. Mayor Krogh is nodding. I think you answered the question.
I was going to say thank you very much. I do appreciate the answer, and I apologize for not being able to stay for the rest of the question period. I've got to get my wife to a medical appointment, but again, thank you for the challenging work you undertake. Much appreciated.
Councillor Perino.
Thank you, Chair. I appreciate I appreciate hearing from your organization today, because we've been elected now over a year, and I really didn't have an understanding about what you did, and I wondered, as I look at this list of who you involve yourself with, and it's great, you've got a good extensive list. I'm just wondering whether or not you ever get involved with some of the neighborhood networks, even NAPSA and those kinds of groups, to help them to understand what you're going through and ask them what they're going through, but particularly our neighborhood groups that are really struggling with what they see on a day-to-day basis right out their door.
I really appreciate the question or the comment, but yes, the answer is yes. And is there opportunity for that to be enhanced? I wouldn't say that any neighborhood associations come to our CAT meetings, and ultimately, we live in a state of world where we have too many meetings and too much that is being demanded of us. So, I completely respect that not everyone is able to be at every meeting and do all the things that they want to do.
However, do you think they are invited, or
yes.
Have you invited them?
Well, so we've actually reached out to the overarching neighborhood associations because we have these forthcoming anti-stigma dialogue sessions, and they're intended to essentially create the spaces so we can have this conversation, for people to voice their concerns and for us to kind of try and educate on some of the initiative efforts that we're doing. So yeah, we have one directly themed around neighborhood and neighborhood associations, and we've started the dialogue of coordinating that for starting the end of January into May. So I'm hopeful. We do also have the final one will be at the Port Theatre, where it's open and to the broader community. So hopefully more people do come out, and so we can feel like we're coming together and having the conversation.
Well, and even if you let council know as well, so that we could come out, because I've never been aware of your meetings and would certainly like to attend, especially when the neighborhoods or some of the groups that are really want to know what's going on, and they want to talk to you about how they're affected. So yeah,
absolutely.
I think that'd be great. Yeah, thank you.
No, I appreciate that. Thank you.
Councillor Armstrong.
Thank you. With the 2 new warming centers coming on, do you have the capacity to be able to assist there?
That, yeah, another great comment. So that is a conversation that we've been having with Risebridge. Haven't had the conversation with the other shelter yet, but that we have our next CAT meeting in 3 days. So I know that will be topics of conversations, and we're trying to respond collectively of okay, who has staffing capacity, because we're trying to pivot the funding that we have right now and to respond. It's not enough. We know that. And really it's the individuals and the individuals coming to support. And then the piece is not just having the money and the people, is what supports do those individuals need, because this is very traumatizing work. So that's the piece where we really need to come together and try and like figure out who's helping who through this process, because you know the last thing we want is those that are, you know, have the capacity to support, you know, are then burning or, you know, negatively impacting their health. So those are important facets.
Thank you. And it's, I think, like every organization, we need the province and the feds to step up with more consistent funding. Thank you.
Councillor Thorpe.
Thank you very much, Chair. Just a question of curiosity comes into my head. Thank you for your presentation. Talking about your relationships with other groups in the community, do you have any contact with the systems planning organization that the city has recently set up?
Well, I'm glad that you brought that up. That was also a facet of the integrated coordinated access work that was done 2+ years ago. And so I have been in contact with them. Nothing is really materialized yet. I wouldn't mind if there's some advocacy from council that this is a functionality, because ultimately we need to work together, because we're having probably very similar conversations or relatable conversations, but they need to build further momentum, and they, you know, otherwise we have further silos and fragmentations in community. So yes, I will continue to make the efforts that I can to, but I would love advocacy for others to say, yeah, the SPO should be working with the CAT and vice versa. So thank you for raising that comment.
Interesting. Thank you. Appreciate it.
Thank you, Councillor Thorpe. And I think it's a good question, because actually I've run into personally a conflict with your CAT meetings being at the same time as the SPO meetings. So in the past, I've been attending the SPO meetings and reading your minutes after the fact, but really appreciate you both reaching out your hands to council today and asking for more support and more involvement. And thank you for the work that you're doing. Oh, I do see a question here from Councillor Manley.
Thank you, Chair, and thank you for the presentation. I sat on the CAT for a little while, just with the Unitarian, and I don't have time because it conflicts with other things, so I've assigned somebody else to do that. But I just know in the past that when it initially started, there was a lot more buy-in from different organizations and agencies in the city, with the city itself, with the fire department, the bylaw, etc. And I'm just wondering if you're having success with rebuilding the CAT in the way that it was originally established years ago.
Yeah, I appreciate that, because that is a reality. You know, I was involved in the CAT again a few years back, and so I'm aware of the evolution or not of the relationship in community. You know, Key and I have both only been in these positions for 6 months, and we all know change occurs slowly, especially if there's been broken trust. So this is big reason why we're here today. So, you know, reestablishing that with you, and then, you know, if there's staff support that the CAT, you know, has a you know, important relationship. So have we seen direct response with building that relationship with staff yet? No. Does that mean that we're going to stop trying? No. And recognizing that, you know, when there's a crisis like this, you know, you're going to what is the most urgent top priority, and maybe the CAT meetings haven't been looked upon as the most urgent priority. But if we could somehow find ways to still continue the dialogue, we need to do that, because we need as many allies as possible. So.
Yeah, I'm just hearing more and more about the need when we had Viha here earlier on, talking about the need for a real comprehensive community response. And I just know from what I had heard, that it wasn't exactly a safe space for everybody in those meetings because of things that were said and blames, blame being meted out in different directions. And so, yeah, I would just hope that if there is an effort to do that, that it carries on in a real positive working relationship, because we do need to be working together in this community to address this crisis. And so I just wanted to say I appreciate your work, and I know you're both new at this table, and so I wish you all the best to continue on this work. Thanks.
Thank you.
There's a cat right there.
Councillor Perino.
Thank you, Chair. Just one more question. On one of your slides, your CAT operational structure, you start off with the Ministry of Mental Health and Addiction. Is that your exclusive funder? I just wonder who's been involved. Love the cat, love the cat. Sorry.
Yes, that's correct. Yes, and then it gets streamlined through the Canadian Mental Health Association and distributed to the CATs across the province.
Okay, so that's who you report to, and
we report to the province, to the ministry.
Okay.
Yes.
Okay,
yes.
Thank you so much, and thank you for your presentation today. Thank you.
Yeah, no, thank you for having us.
Thank you to both of you for being here today. We're going to move on to our next presentation now. It's agenda planning, to be introduced by Karen Robertson, Deputy Corporate Officer. Thank you, Karen.
Thank you, Madam Chair. Before the committee today is just a list of the upcoming topics for the future GPC meetings. There has been a slight change just based on availability of consultants. So, for example, the development approval process review that was scheduled for February 12th is now being moved to January 22nd, and the Dave Whitty presentation will be moving to February 12th. The other thing that we are just moving forward is the e-mobility. We're going to be coupling that with the active transportation update, so it should even itself out. And that's, if council or the committee has any questions about any of the topics, or if there's any other suggested changes or additions.
Councillor Armstrong.
Thank you. Yes, I have a concern about the Nanaimo Operational Center project. I recall that we wanted to have that in the evening time, if at all possible. And I believe the date when you have the e-town hall is too far into the process, because I believe January 18th is when the APP starts. So that's only going to leave people 2 weeks to get that information, and I think we'll be severely criticized for that. So I would like to see that e-town hall or the GPC be on the evening as we had requested originally. Or the other option maybe is, I believe our next meeting is January 15th. Perhaps that could be moved to there instead, because I'm very concerned about the fact that people have been complaining they don't have the information before the APP process starts, and we're not giving them information until 2 weeks after the APP starts. So I'd very much like to see if that's possible to have that moved.
Madam Chair, January 15th, which would be the first council meeting in 2024, would be a possibility. The call for reports has not gone out yet, so there is still the opportunity to work around it. Should the committee want to have that booked for January 15th, we could just move it forward.
I know Mr. Sims had said before he would have been prepared to go today, so would that be a problematic if it's possible to get you to move to the 15th on the evening session to talk about the process, the project, et cetera?
Thanks, Chair. Just through you to Councillor Armstrong, I think one of the purposes of having the discussion of the GPC was so Council could get into it from a sort of do that deeper dive, as Councillor Manley first alluded to. And usually at council meetings you wouldn't necessarily have that level of deeper dive. But having said that, we could certainly provide a presentation and anticipate some of the questions that may come up. And then maybe what we can do is have some further thought around the viability of an e-town hall. If we're having an evening presentation from staff, there's an opportunity for people in the audience to question or delegations to sign up. There may not be a need to have an e-town hall at the same time, but that's just sort of initial thinking.
I guess my concern is when you do a GPC during the day, people can't come, and we hear that loud and clear. And the purpose for the GPC was supposed to get more community involvement, but when we have them during the day, people work. So that's a big concern for me, and I did hear that from people in the community, that they want to be more involved, they want to learn more about the project, but they can't afford to take time off of work. So if we could even have a evening GPC, like we talked about that before when we said something that is important to the public, we would like to see them go at night, and I know I did mention that previously.
Thanks, Chair. I just, a quick note that a GPC or a council meeting wouldn't be the only communication that we would be putting out. There's quite an extensive communication plan in the works, including quite a bit broader of advertising and, of course, all of the social media channels, putting posters and so on in facilities, having a couple of open houses at Public Works, including bringing the media in on just sort of a guided tour on during the day to see the action, and then perhaps an evening and a weekend with the public as well. So that would be the intent. So again, not just a council meeting as being the sole location for.
I guess just my concern is being very active on that page and seeing all the concerns that are raised. They don't understand the project, and they don't understand what's been written on the project. So I think if people had the opportunity to come and ask the questions directly, it would be a lot simpler. Or to send, even if we had them send a group of their questions, and we could maybe perhaps do a video that could be circulated on Facebook, on different sites, because it's really causing a lot of issues in the community, and it's growing and growing. And I just, like, I think it's the communication piece again. Like, it's, people don't understand the need of the project. Like I've said, I've been replying to, why can't you use the empty save-on building? They think you can put your trucks in there. They don't understand what's required. So I think what we're missing on is really getting a point why this is really needed. It's not as about just space. It's not about, you know, it's with the advent of the, you know, the bigger trucks, the garbage trucks. What was successful in 1960 is no longer successful, and this is why we need it. So even if there was the Q&A answers, I think, yeah. Anyhow, that's just my 2 cents. Others may not agree with it, but I just think it's the communication piece. And I know you guys have done a lot of really good work around it, so please don't take it that way. Nope. And I think that it's just a way, how can we get more people involved? And that's one good thing about this, is people are starting to pay attention to city politics. Thank you.
Can I go to Councillor Gesselbrecht, then Councillor Thorpe? You're on mute, Councillor.
Just 2 questions. One around the E-Town Hall. Is it possible, like, we'll be taking questions on the operations center? Is that during a council meeting, or could we just possibly put the information and discussion that would be happening within the Nanaimo Operations Center from the GPC on that February 5th date?
Chair, I think either or, quite honestly. One of the engagement pieces that we're shifting to is using the Get Involved page, so that'll be an opportunity to simplify the information. Councillor Armstrong sent around the town of Squamish similar project, and it was a much simpler and cleaner web page or landing page, and that's our intent, to shift the content, not the detail, leave the detailed content behind on the project page, but have certainly have the Get Involved page as a good point for community engagement as well.
Okay, thanks. Yeah, I just saw that it's the council. February 5th is the council meeting, so that might not be feasible to put those 2 together. My question I had was just with the active transportation update. What's currently being discussed? What's currently the vision for that update? The contents of it.
Thanks, Chair. Through you to Councillor Gesselbrecht. I think one of the main focuses was going to be on the e-mobility strategy. I sent Council just a quick update on the provincial pilot project, so bringing that forward and having that options discussed, as well as having discussion, as we talked about during the project planning session, around what projects are still outstanding for active transportation within the core area of the city. And then I think we'd probably round it out with active school travel, the work that we're doing with the school district. So it's a sort of a fairly intensive overall day.
Okay. Yeah, I was planning on putting a motion forward, not today, but at the next GPC, just specifically around our bike lanes, just to get a report on the map of what our plan is in terms of the key of our not the combined sidewalk and bike lane infrastructure that was presented, but just specifically on the bike corridors, and then sort of where we're at currently and where the gaps are, and then opportunities for, at least completing the core, sort of that minimum grid of our bike lanes. And I just wanted clarity if that was included in that update, but if it doesn't sound like it, so I will, not this GPC, but I'll come with a more descriptive motion in the new year. Thank you.
Chair, if I could apologize to Councillor Gesselbrock, I was trying to say that, but maybe jumbled my words. But yes, it is included in that particular day. That was the intent of one of the elements of that. So,
okay.
Yeah.
Okay, so if that is included, would it be possible, as the information presented is specifically on the bike the bike network, in terms of the current plan once it's all built out, because I think that's in the OCP, presenting that, and then where we're currently at, and then gaps and opportunities. Would that be possible to ensure that that specific information is included?
Yes. Through the chair.
Great. Thank you.
Councillor Thorpe.
Thank you, Chair. Just going back to Councillor Armstrong's concerns regarding the Operations Centre, and thank you, Mr. Sims, for the ongoing efforts to communicate with the public. I know it's a challenge to get information out, but I do, excuse me, I do agree with Councillor Armstrong that the sooner we open this up to the public, I think the better for their education. And I would support the idea myself of an evening GPC in January, the 15th was mentioned, and combine that with a staff presentation to council, and then the public, if they're in attendance, would have an opportunity to ask specific questions. And to me, that would negate the necessity, pardon me, of a separate town hall later on in the new year. I see that as being quite redundant, really. So that's just my thoughts. Thank you.
Councillor Manley.
Thank you, Chair. I am going to third that because I agree with Councillor Armstrong and Councillor Thorpe. I think we need to get out in front of this. Having a town hall, on the NOC, the Nanaimo Operations Center, after the AAP has already opened up and been going for a couple of weeks, feels more like damage control than getting out in front and actually explaining to people what this is about. And over again, we heard from people that they don't understand this project. It's not just that they don't like the AAP, that they don't understand the project. And so if the objective is to have another AAP and not have it go to referendum, then we need to explain it to the public, and we need to do a good job of explaining it to the public. So,
Ms. Robertson.
Thank you, Madam Chair. January 15th would be the first council meeting in January, so perhaps if council is going in that direction, a motion to direct staff to explore a special evening GPC somewhere prior to January 18th, so that we can check on availability on the facilities here to make sure that that's possible.
So
I see. Yep. Councillor Manley moving that motion, seconded by Councillor Armstrong. Any discussion? All those in favor? Motion carries unanimously. Councillor Manley, anything else?
no, that was really it. I mean, I also feel like we should be sending something to voters. I know it's not cheap to do, like to send out an information package. It's $30,000, $40,000 to mail out our tax forms, but you know, we saw an article in the Nanaimo News now saying how many times they have been talking about this project and discussing it for several years. People aren't paying attention to the media. And the way social media works these days, you don't get media in your social media feeds, and you don't get the city of Nanaimo in your social media feeds. You have to go and really search this stuff out. And so I'm not sure, you know, what the best way to address that is, but
I think Ms. Robertson would like to respond.
Thank you again. Just some things to explain in terms of communication and how you balance that out for an AAP process under best guidance from the province. And one of the things that one has to be mindful of is consistency, expectations, and ensuring it's not being promoted one way or the other. So further to the motion that you made previously about what would be the expectations of how we would consider AAPs in the future, where they're run in a consistent manner. If you do that in advance of that policy direction, you may be setting yourself up for a precedent for all future AAPs. And right now, we only have a budget of $10,000 per year. Anything more than that would be taken away from a referendum budget. And right now, a mass mail-out would be in the neighborhood of around $30,000 or so. Flyers is a little bit cheaper, in the neighborhood of around $13,000. However, with flyers, you end up getting people in the area of the RDN, and it could become confusing. So we also are not utilizing consultants, where there was one previously that it was. We're using our existing 3 communications staff. So right now, and I think Mr. Sims alluded to it, where there's a media tour planned in January. There's open houses at Public Works. There'll be some pre-registrations for that. The Get Involved page, some radio and newspaper advertising, and some information boards and city facilities. So that's what's being done moving forward. So just that additional information.
yeah, thanks for that. I know we had an AAP earlier on in the year that to remove a piece of parkland for the Tuxton project, and we got a handful of responses, and to spend $30,000 on non-responses if that's the precedence we set. I would be interested in having this conversation when we do talk about how we approach AAPs in the future.
Before I go back to Councillor Armstrong, I appreciate Councillor Manley bringing that up, and I do think it's something that warrants serious consideration. Even if it does set a precedent going forward, this is the amount of money that we're looking at borrowing is unprecedented as well. And just because of the way that the media landscape is changing so much, like people don't get the physical paper, so they're not going to see the full page ad in the same way that they might in the past. And even with our own Facebook advertising, like doing the e-town hall thing, like people aren't seeing what the city is posting. The city had a page during the e-town hall for people to post questions, and not a single question was posted on there. I was the only like on the post. So it's not a great sign that people are actually seeing what we're putting out. So I see us really struggling with how to make sure that the public feels like we're not hiding information from them, when at the same time they're simply not accessing news media or the city website in the way that we might hope and expect. So yeah, I think it's a really tough one, but I would be in favor of sending something out on this if it means that it builds trust in the city's processes, and it builds awareness about the need for the project. Councillor Armstrong?
Thank you. I was just going to say, perhaps if we are able to move the NOC project information on the 22nd to a different date, perhaps we could do the APP process then and have this discussion in lieu of that, because I do think we need to talk about it further. Well, we've asked to move the Nanaimo Operations Center project from the 22nd to another date. So if that's possible, then we could do the APP process then.
So if I'm hearing you correctly, with the a special GPC meeting with the evening prior to the 18th, and then instead of the Nanaimo Operations Center project, it would be a discussion on the AAP process. Okay.
Yeah, I think if people are, because I think we could talk about that, and I do agree, I think we need to really, it might even be that any project over 25 million will be a mail out. I mean, there's things we can talk about, or there's a difference between money versus land as well. Like some of these APPs that we do, they're very minimal, it's mostly land exchanges. But when you start talking hundreds of millions of dollars, which, and we've got a few coming up, I think that's important for the public to know. So I think an APP discussion would be appropriate.
So just for clarification, you're talking about moving a discussion about the way we approach AAPs earlier, and would we at that same meeting also be providing information in greater depth on the operation?
No, because we've asked for special GPC to do that, NOC. And so if that happens, if we're able to do that, then that could be removed from the 22nd meeting, because we'll have had our own at nighttime, and then that could fill in that spot, have the APP discussion then.
Okay, thank you. Not seeing any further questions from council.
Could I just get a motion to add, to remove the Nanaimo Operations Center project information topic and replace it with the AAP process?
I'll move that if successful in finding a new date for special GPC. Thank you.
Moved by Councillor Armstrong, seconded by Councillor Manley. All in favor? And those opposed? Carries unanimously. Thank you. And our final item of the day is 2024 Association of Vancouver Island and Coastal Communities resolutions. Ms. Robertson?
Thank you. So as council is probably familiar, each year the AVICC, or Association of Vancouver Island and Coastal Communities, provides opportunities for councils to bring forward resolutions for consideration. And being brought forward, if, for example, if Councillor Perino brought one forward, you would be the person that would advocate for it at the conference. If it's supported at the conference, it would move forward to the UBCM, and if supported at UBCM, it would move off onto the province. And so this is sort of council's opportunity to identify any topics that you would like to see move forward, and that would come, because the deadline is February 7th. The motions have to be, or the resolutions have to be considered with a formal motion by council, so we would be coming back on January 24th. Right now, I got one this morning that the CAO had directed staff to already start working on, and that's emergency shelters in compliance with BC Building Code and BC Fire Code. And that's given the fact that you have to have more individuals in, and you're then violating the building code or the fire code. And so part of it will be asking about UBCM requesting the province to work with the Building Safety Standards Branch to establish some reasonable variances to the codes to enable emergency shelters to remain open. So that one is in the works, but if council members have any other topics that they'd like to bring forward, this would be the appropriate time at which staff could then prepare appropriate resolutions and background information.
Thank you. Question from Councillor Perino.
Yes, thank you, Chair. I can't think of the wording offhand, because Mayor Krogh brought it up, and then Dr. Walmsley actually addressed it as well, and it's having specialized care for individuals who are suffering from brain damage due to drug addiction overdoses. What we are needing is more beds available for those people that are really struggling to get their help when their brain has been so affected. And I don't have the wording for it, but I just think, for us to just say that, Mayor Krogh said you've got to have more beds, and Dr. Walmsley then agreed, saying, yeah, it's true. We need more help. But I think we need to take that to the next level to say to the province, somehow we have to have more beds for those people who've been so badly affected by the drug overdose toxicity. And I'm not sure how to phrase that. Or if do you need a seconder? Is that a motion, or is there something along that lines?
Just trying to craft something is a little bit challenging. However, at this point, it's just more of a brainstorming session, so we can come back once we've had an opportunity to research the topic. So I think staff can take enough from the direction that you've indicated now, and then we would come back with something.
Yes, and I'd love to speak to that when we go to the conference. I'd love to speak to that one, yes.
So I'll put something about advocating to the province for more beds, and I'll flesh that out for you.
Thank you, thank you.
Councillor Armstrong.
Thank you. Yeah, I'd like to look at the province funding the RSP mental health positions. I think because we haven't seen an increase in the provincial funding model here, so I think it would be a good way for them to help us address the crisis that a lot of these people aren't even in our community. So provincial funding for mental health positions for the RCMP. And then I had one other one. And then also an advocacy position for those who aren't suffering from addictions or mental health. And we've got a lot of them living in our woods right now that are in recovery that don't want to go to supportive housing because they don't want to be around users. So advocacies and for those to go into places where they're dry. Like we hear that a lot from those in recovery. I can't go back to that spot. You know, or even if, you know, just throwing out like Dr. Summers said, you know, maybe we should be looking at, you know, the province securing different apartments in different buildings to put people in recovery in theirs instead of the stigma of being lumped into one area. Maybe that's an approach we need to look at. Just throwing those out. Thank you.
Councillor Manley.
Thank you. I'm wondering, so these are all going to come back and we're going to have a vote on them in a January meeting to discuss them then more fully?
Part of what we have to do is look at the legislative framework and figure out how this could work, because we would have to provide the appropriate background or information. So it's just a little bit challenging today because I've jotted down the ideas of what you'd like to see, and so I'd like to take that back, and the senior leadership team will discuss it, see how we can move that forward and putting them together hopefully in some form of a resolution that we can bring back for council's consideration.
Yeah, because I'll probably think of some things after this meeting, and I know last time I just sent in some kind of rough drafted resolutions, and then we looked at them and took them to a council meeting. One of the things I was thinking about is this whole 30% protecting biodiversity by 2030, about having funds directed for cities and municipalities to be able to protect areas within urban containment boundaries that are ecologically sensitive. And so having a separate funding stream, because a lot of these funding streams are created for more wide open kind of spaces, Crown land in particular, but we do see a need in this area for protecting some biodiversity within the actual bounds of the city.
Through the chair, did you say that you have already submitted information on that?
No.
Okay.
But that's that's an idea that comes to mind right now, and there may be some other things. I mean, just like absorbing all this information we were given by VHA and Dr. Summers, and where things are falling down, and how we don't have this kind of collective response that we need. We're seeing kind of piecemeal approaches to dealing with a crisis that's not actually working. And so I'd just like to be able to think about it a little bit more and then send something in.
And so any additional background information that could be provided to staff would be very helpful, just because of the topics. They could warrant a bunch of research on their own. So any information that you can provide would be greatly appreciated.
Okay, thanks.
Ms. Robertson, are you looking for us to move the motion that's on the agenda here? Motion for...
I'm struggling because I can't, these are ideas and concepts, and to put a specific resolution down is challenging because the way
right, so it's just that we identify resolutions and background material, and then at the January 15th meeting, then we would direct staff to submit those. So you do want us to move the motion that's on the agenda?
What I've got here is topics for consideration, so it's difficult to put it into a motion. I think we've identified what topics council is interested in, and then we'll come back with something a little bit more formal
Okay,
for
we'll deal with it
consideration.
then. Okay.
Thank you.
Okay, thank you. And not seeing any questions on the question period sign-up sheet today, so motion for adjournment, Councillor Armstrong, seconded by Councillor Prino, all in favor? Motion carries.